Okay, I don't know how many of them are seen it. I will just ask one person. So I see 50 people now. The first name I get is Rashmi. Rashmi, how are you, ma? Can you unmute yourself? Have you received the notes? Have you opened up the notes? Rashmi is not very friendly. She's not willing to talk to me. Soundarya Sendil, how are you? Any volunteers who can open up and can they unmute themselves and talk, madam? Swaroop.
Sir, it has
Hello?
been.
Can any one of them unmute and talk?
Hello. Good morning, sir.
Yes.
This is Dr. Nagaraj from Sri Devaraja Medical College.
Hey, Nagaraj, how are you?
Fine, sir. How are you, sir?
Yeah, I'm doing great.
I
Are you
hope
able to?
you are feeling sleepy.
No, not yet. Probably after 20-30 minutes. Are you able to open up my notes? Is it opening up?
Yes, sir. They sent it to the mail ID for everyone shared, sir.
Okay. Who is the great person on the last page of my notes? I just want to check whether you have gone to the last page.
Oh, okay.
And had gone through. That's fine. I'm just having some fun with you all. Super. No problem.
Yes.
So let us start with the first part of the. I will just hide the floating meeting control. Mute all. How to close this participants list, because that's interfering with my screen. So that participant thing is there on my screen. Are you all able to see it, or only I am seeing it?
Sir, only you're saying it, sir. If you click participants again, it will close, sir.
It will close. Okay. Yes.
Excuse me, sir.
Yes.
And last part of your material slide is the Steve Jobs, sir, Apple founder.
Yes. Thank you very much, Nagaraj. I love
Thank
Steve Jobs. He is my mentor.
Yes, sir. He is very good.
Yeah, I learned a lot of things from him. So let
Yes,
us
sir.
go through the first
Thank
part. Thank you, Nagaraj, which
Thank you,
is
sir.
introduction. Sarcoma means swelling made up of fleshy tissue. And sarx means flesh and oma means swelling. You all know oma is swelling. And the latest WHO classification has more than 100 types and subtypes of soft tissue tumors under its belt. And the main treatment of sarcoma is surgery, and the radiation and chemotherapy depends upon the other factors. And the chemotherapy, previously it's only cytotoxic agents. Now we have targeted therapy. So whenever you say chemotherapy, is it cytotoxic agents or targeted therapy? We have to specify. And pathologists play a very vital role in soft tissue tumors, because the recurrence rate depends upon the margin status, and we are the people who confirm the margin status. Okay, so the recurrence of any tumor depends upon whether it is there in the margin, and we have a very critical role in assessing the margin. And the metastasis and 5-year survival depends upon histological type and grade, where again we play a very important role. And the most recently appreciated role from pathologists is molecular classification, where we can use the targeted therapies. Okay. We will talk about it more, and we also play in that role. In the follow-ups of soft tissue tumors, 20 to 30% of them they recur, and 30 to 50% of them will go for metastasis. And the 5-year survival of a high-grade sarcoma is 55 to 75%. And probably these numbers will be changing because of the targeted therapies. These are all the numbers available right now. So in short, the pathologists play a very vital role in the diagnosis, in the prognosis, and in the theranosis. That is the terminology where we help the clinicians by telling what targeted therapies can be given for a particular tumor. Biologically, the soft tissue sarcoma is divided into, soft tissue tumors are divided into benign, intermediate, which is locally aggressive and rarely metastasized, and malignant. This is very, very essential because the recurrence rate and the metastasis depends upon these findings. The local growth, usually in benign, it is non-destructive. If you see the examples, you will be able to correlate them very well. For benign, take a simple lipoma, it is a non-destructive lesion. There is no recurrence and metastasis, and the treatment is local excision. Whereas a desmoid tumor fall under intermediate category, which is locally aggressive. It is having a destructive growth, means infiltrative growth. Even though it's benign, the margins are going into the adjacent structures, so it's a destructive growth. So the recurrence is there in intermediate category. This recurrence is mainly because of the infiltrative margins. It is because of incomplete removal. Even though we put for wide excision, grossly the surgeons cannot see the extension of tumor into the adjacent structures, and so they may leave some of the tissue, tumor tissue in the patient, and that may recur. Whereas the metastatic rate is nil in cases of locally aggressive intermediate tumors, and the treatment is wide excision. There are some tumors like desmoplastic, so DFSP. Here, it's a destructive local growth, the recurrence is present, and the metastasis is also there, up to 2%. The DFSP can metastasize up to 2%. So they need wide excision with the follow-up. Whereas in malignant tumors, the growth is destructive, recurrence is present, and metastatic rate is high. That's why we have to go for radical excision from adjuvant therapy, and leiomyosarcoma is the best example of malignant tumor. So this table is very, very important, and I thought whenever it is important, I want the participant to take a snap of it. So you will see this selfie sign. That means you have to take a snap of that slide. Coming to the part to how to approach the soft tissue tumors. Soft tissue tumors are mainly primary or secondary. We are going to talk about only primary in this discussion. And as I told before, it's divided into benign, intermediate, and malignant. And how we determine these? By looking at the light microscope and by doing ancillary studies. In the light microscope, we see in the low power and high power. In the low power, we see the pattern. And I will be talking about the pattern in a minute. And then junction of the normal and tumor, whether it is pushing or infiltrative. Most of the soft tissue tumors doesn't have capsule, but they are all well circumscribed in a benign end, whereas it will be infiltrative in a malignant end. And then we have to see the cellularity of the lesion. Is it hypercellular, hypocellular, or both hyper and hypocellular? We have to see the stroma in the background, and we have to see the margin status in the low power. After finishing those things in low power, we go to the high power and see the cytological ATPR, what we call it as pleomorphism. And we have to look for mitosis and apoptosis, and we have to count in 10 high power field, or nowadays they are calculating it in millimeter squares. And then we have to look for necrosis and hemorrhage. This necrosis and hemorrhage is already noted in the gross examination, but we have to confirm it under the microscope. Coming to the ancillary studies, the exam going PGs, you have to always remember histochemistry first, even though I will be talking very less about or nothing about histochemistry, but you have to talk about histochemistry first, followed by IHC. And then other additional studies are karyotyping, molecular studies, which includes genomics and proteomics. When you are comparing the cells, normal cells, to determine the pleomorphism, you have to compare it with the normal cells. And the new thing, or whichever I come across now, is we have to compare it with the endothelial cells to see the pleomorphism. I will show it to you in a minute. And this needs a snap at this time. So I told you the endothelial cells has to be compared. This is an endothelial cell in the stroma of a tumor. You can see the flat cells with some hobnailing is there, but they are very flat. And whenever the tumor is made up of cells similar to that, that's a benign tumor. Okay, this is a hemangioma where the tumor cells or tumor cells forming the blood vessels are very similar to tumor cells in the normal. And this is a glomus tumor. You can see the perivascular location of these tumor cells, and these cells are larger than the normal endothelial cells, and that's why it is known as, if you want to grade it, it's grade 2, and this is grade 3, which is very pleomorphic. So by comparing the endothelial cells, the atypia can be grade 1, grade 2, and grade 3. Grade 1 is mainly by similar to the benign looking endothelial cells, whereas the grade 2 is more larger cells, and whereas grade 3 is much more pleomorphic cells. And this comparison with endothelial cell, it might have given in many textbooks. I learned from Gerard Gardner, and many of you may be knowing. I have given the Twitter handles. And by the way, these are all my communication method to freely talk to my friends and my juniors. In the Twitter, my handle is at @rdpatho. In Facebook, it is Swaminathan Rajendran, and I have my own channel in YouTube, and Dr. S. Rajendran is the name. And these three people I love regarding soft tissue tumors. See, we used to have mentors, but now I think the pathology is advancing so much. For every division of it, you should have very good mentors. Gerard Garner, Jason Hornick from Boston, and Elizabeth Montgomery, madam. She was in Johns Hopkins, but now she moved to Miami. So these are all the three wonderful people from whom I learned a lot by listening to their videos. I know them very well, but they don't know me. And it is their problem. It is not my problem. If you know somebody, you all know Modi, but Modi doesn't know you all. And that is Modi's problem. And that's how we have to approach the life. So I thank these three beautiful people for educating me in soft tissue tumors. So I talked about the patterns. These are all the 6 patterns you have to remember. Fascicular tumor means they are all arranged in long bundles or intersecting bundles. Okay, spindle cells with indistinct cell border, moderate amount of eosinophilic cytoplasm. Why I say moderate amount of eosinophilic cytoplasm? Because the nuclei are separated. Okay, even though the border is indistinct, depending upon the distance of the nuclei, in between the nuclei, you can guess the amount of cytoplasm. So this is a fascicular tumor. And this is a myxoid tumor where you see hypocellular, largely myxoid, means more bluish, watery material. So this is a myxoid tumor. And these are epithelioid tumors. The cells look more like epithelium. Oid means resembling. Here, these are all mesenchymal cells that look like epithelial cells. That's why they are known as epithelioid pattern or epithelioid tumors. And here, as the name indicates, these are round cell tumors. Here, the cytoplasm is less because the nuclei are touching each other or overlapping each other. That's how you have to know the amount of cytoplasm whenever the cell border is indistinct. So these are all the round cell tumors. And these are pleomorphic tumors. You can see many giant cells, mononuclear and multinuclear giant cells. And when do you call definition of pleomorphism? Take the smallest cell and take the largest cell. If it is more than 3%, it's pleomorphic. Again, it is, I learned this from Gerard Gardner. So that's the definition of pleomorphism. And lastly, vascular tumors, where the tumors form a lot of blood vessels. Okay, so these are all the 6 patterns you have to know in soft tissue tumors. And this is a composite picture where you see all the 6 patterns. I request the audience to take a picture of this. I think selfie is there. So these are all the conventional teaching of soft tissue tumors. With that background, I have to go to updates in soft tissue tumors. Let us first start with the WHO 2020 classification. There are 12 major divisions in the soft tissue tumor classification. In all WHO classification, whatever may be the organ, first you have to understand what are all the major headings in that classification. In soft tissue tumors, it is tumors of adipocytes, fibroblastic and myofibroblastic tumor, so-called fibrohistiocytic tumors, vascular tumors, perivascular or pericytic tumors, smooth muscle tumors, skeletal muscle tumors, gastrointestinal stromal tumors, chondro-osseous tumors, peripheral nerve sheath tumors, tumors of uncertain differentiation, and undifferentiated small round cell sarcoma of bone and soft tissue. These are all the major headings you have to remember. And in each heading, you have to know the conditions that are benign, intermediate, and malignant. Remember that table I asked you to take a picture of it. That will help you to determine whether a tumor is benign, intermediate, or malignant. So 12 into 3, at least 36 tumors you have to remember. For example, adipocytic tumors, benign is lipoma, intermediate is atypical lipoma, and malignant is liposarcoma. Like that. I'm making it very simple, but it is not that simple. But the concept is know the major headings and know one member at least in the benign, intermediate, and malignant categories. And with that background, I'm going to show you all the tumors. Please believe me, I'm not going to bore you by reading all these things, because these are already given in my notes. So whenever you see fatty tumor, you see whether it is benign, intermediate, or malignant. When it is malignant, is it well differentiated, dedifferentiated, myxoid, pleomorphic, or myxoid pleomorphic? Okay, this is how you have to approach. This is for adipocytic tumors, and I'm not asking you to take pictures of them because I have given these things in the in my notes. Fibroblastic and myofibroblastic is the biggest criteria in the 2020 WHO. So again, benign, intermediate, and intermediate itself is having locally aggressive and rarely metastasizing, and then malignant. And this is for fibrohistiocytic tumors, benign, intermediate, and malignant. For vascular tumors, benign, intermediate, and intermediate, locally aggressive, and rarely metastasizing, and malignant. Pericytic tumors, benign, intermediate, malignant. Smooth muscle tumors, benign, intermediate, and malignant. Why I'm repeating this benign, intermediate, and malignant? Because you have to make that embedded in the white matter of your brain. Skeletal muscle tumors, benign, malignant. Gastrointestinal stromal tumors, it's no benign, intermediate, malignant, because they are all malignant potential. So they have to be divided into low grade, low malignant potential, intermediate malignant potential, and high malignant potential, depending upon the size, mitosis, and location. Okay, in the stomach we have different criteria, in the duodenum we have different criteria, but these criteria you have to remember 3 of them: size, mitosis, and the location. Chondro-osseous tumors, again benign and malignant. Peripheral nerve sheath tumors, benign, intermediate, and malignant. And tumors of uncertain differentiation, benign, intermediate, locally aggressive, intermediate, rarely metastasizing, and malignant. Undifferentiated small round cell sarcoma of the bone and soft tissue. This is previously known as Ewing sarcoma, but now it has 3 more members: round cell sarcoma with EWS or non-ETS fusion, CAC rearranged, and BCAR rearranged. We will see them again and again. So the summary of the WHO 2020, you please remember these 12 subtypes. Now we are moving to next one. What are all the changes? And before that, I just want to ask, Madam, is there any questions, Madam? Kalani, Madam?
No questions, sir.
Super. I request the attendees to feel free to ask me questions if you are not able to understand anything, or if I am going too much too fast, you please request your questions and I will answer them and we will proceed. So what are all the changes? Again, there are 12 major headings and there are 23 changes in the WHO 2020. Remember, 2020 has 23 changes. And what are those changes? There are 12 new entities. One entity was renamed, 4 of them are reclassified, and the 6 of them are deleted. If you have not read the previous 2013 4th edition, you don't have to worry now because you are starting a new knowledge building. So you don't have to worry about it. But in the exams, they may ask you, what are the changes in WHO 2020 soft tissue tumors? So you have to remember 23 of them, and this is the breakdown. And let us see, in adipocytic tumors, there are 2 new entities. One was reclassified and one was deleted. In the fibroblastic and myofibroblastic, 3 new, 1 reclassified, 1 deleted. And so-called fibrohistiocytic tumor, that malignant fibrous histiocytoma was deleted. In vascular tumors, 1 was added and 3 were deleted. In smooth muscle tumors, 2 new entities. In skeletal muscle tumors, 1 of them is reclassified. In peripheral nerve sheath tumor, 1 of them are renamed or reclassified. And tumors of uncertain differentiation, there is 1 new entity. And in undifferentiated small round cell sarcoma of the bone and soft tissue, there is 1 reclassification and 3 new members in that group. So if you add all these numbers, it will come into 23. And I want to take you a snap of this just to tell you what are the changes happening in each major headings of the soft tissue tumors. And let us now see the new entities and what are all the changes in these tumors. In adipocytic tumors, atypical spindle cell or pleomorphic lipoma, ASPLT, is a new entity along with pleomorphic myxoid liposarcoma. Previously, we had pleomorphic liposarcoma, we had myxoid liposarcoma, but now they included pleomorphic myxoid liposarcoma, where in the same tumor you see myxoid areas and the pleomorphic areas. And the extrarenal angiomyolipoma is shifted to uncertain differentiation, and it is known as PCOMA. You all know perithelial tumors. So that PCOMA, AML belongs to that PCOMA. And the extraadrenal myelolipoma was deleted from the 2020. Take a selfie of that. So this is the tumor. What I made up all this history depending upon the prevalence. Okay, this is more common in this entity is more common in middle-aged males and usually happens in the extremities. It has a lot of atypical. These are adipocytic tumor. Okay, atypical spindle cells, and they show adipocytes, and you may see in high power lipoblast. And some pleomorphic cells are there. When you compare the smallest cell and the largest cell, it is more than 3 times enlargement. And the background is more myxoid or collagenous matrix. Here it is more of collagenous matrix, whereas here it is myxoid matrix. And when you do immunohistochemistry, CD34 and S100 are positive with the loss of RB gene, but MDM2 and CDK4 are negative. Because they are molecularly negative for liposarcoma markers, these are now known as atypical spindle cell or pleomorphic lipoma. The recurrence rate of them is high. That's why we have to differentiate this from lipoma. But there is no chances of metastasis or dedifferentiation. So they belong to more intermediate category of lipomatous tumor. This is one of the new entity in the lipomatous tumor. The next tumor, as I told you before, it shows admixture of more classic myxoid liposarcoma and the pleomorphic liposarcoma. And again, they are negative for MDM2 and CDK4. SN1 protein may be positive or negative, and they are the pleomorphic, myxoid pleomorphic liposarcoma. So it is like a combination of both myxoid and pleomorphic liposarcoma. It's very common in young girls, okay, and more common in the mediastinal mass, mediastinal. Okay, so that you have to know. Coming to the fibroblastic and myofibroblastic tumors, angiofibroma of soft tissue, UWSR1, SMAD3 fibroblastic tumor, and superficial CD34 positive fibroblastic tumor are the new entities. Acral fibromyxoma is moved here from the uncertain differentiation, and the calcifying fibrous tumor was deleted. So when you are talking about the tumor entities, some of them you can make the diagnosis by H&E itself. Some of them need IHC, and some of them need molecular, new surrogate IHC marker or molecular findings that you have to remember. For example, angiofibroma, we will be seeing it in a minute. You can diagnose it in H&E. Whereas superficial CD34 positive fibroblastic tumor, you cannot make it on the H&E. Okay, you may see the superficial cells with a lot of pleomorphism, and but you have to do the CD34, and it has to be positive to call it as superficial CD34 positive fibroblastic tumor. Similarly, to call it as EWSR1 SMAD3 fibroblastic tumor, you have to do this molecular workup. I hope you understand. In the H&E, you form the differential diagnosis, and then you do the IHC markers and the molecular workup, and depending upon the finding, you give the name for the tumor. Take a picture of this. So this is a tumor that's very common in the middle-aged females, more near the major joints in the extremities, and microscopically they show bland, uniform, short spindle cells with a myxoid or collagenous background, and you can see a lot of small, thin-walled branching blood vessels, and those branching blood vessels are highlighted by the CD34 stain, and you can appreciate more the spindle cells and the vascular. These are fibrous cells, so it's fibroma, and these are all blood vessels, so they are angio. So when you combine both of them, they will become angiofibroma of soft tissue. This tumor, which is very common in female middle-aged with extremities, it shows hypo and hypercellular areas, central hypocellular areas which are more made up of collagen, and the peripherally fascicular pattern of hypercellular areas. And these tumors are ERG positive, and all the other markers are negative. You know, ERG is a molecular marker of endothelial cells. But this is one of the tumor where non-endothelial cell tumors can also be ERG positive. And so the diagnosis in this is when you do molecular workup, they all will show EWSR1, SMAD3 positive. And so they are known as EWSR1, SMAD3 positive fibroblastic tumor. This tumor, this is the skin, dermis, and the tumor is mainly in the subcutaneous tissue, and it shows highly pleomorphic. Okay, previously we used to call it superficial malignant fibrous histiocytoma, and they express CD34 very nicely, and cytokeratin can also be positive. This is the CD34, and you can see better the tumor location in the subcutaneous tissue. So this is a superficial tumor that is CD34 positive. So it is known as superficial CD34 positive fibroblastic tumor. They will show a lot of atypia, but the mitotic rate is less in this condition, and they are very common in the lower extremities in males, middle-aged males. Fibrohistiocytic tumor, the only deleted tumor is malignant fibrous histiocytoma. There is no more malignant fibrous histiocytoma in the soft tissue tumors. They are, when you look into them carefully, they belong to or they fall into other categories. For example, what we call the myxoid MFH is now known as myxofibrosarcoma. Inflammatory MFH is like inflammatory variant of dedifferentiated liposarcoma. Okay, the new molecular markers are helping to distinguish specific tumors from this waste basket diagnosis. Previously, this is like a waste basket diagnosis. Whenever all the IHC markers are negative and when they show high-grade nuclear features and possibly some histiocytic markers positive, we used to call them malignant fibrous histiocytoma, but that terminology is deleted now. Take a selfie of this. Now going to vascular tumors, the new entity is anastomosing hemangioma. The terminology is angiomatosis, polymorphous hemangioendothelioma, and giant cell angioblastomas have been deleted. And take a picture of this. And this is renal tumor. Okay, the history, it is more common in male, middle age, and it can more commonly seen in the kidneys and in soft tissue. They show this is a well circumscribed tumor. You can see a lot of blood vessels that are interconnected with each other. So they are all anastomosing blood vessels, and you can see it in high power. They show hobnailing, and some of them may show hyaline globules in the cytoplasm. And here you can see darkly stained lymphocyte-like cells. But when lymphocyte-like cells are seen in clusters like this, you have to think of extramedullary erythropoiesis. And here the terminology clarity is, whenever you see RBC precursors, it is erythropoiesis. WBC precursors, it is myelopoiesis. When you see RBC, WBC and megakaryocyte precursor, then only you have to call it hematopoiesis. Okay, and this is a tumor that is more commonly present with extramedullary hematopoiesis, and the name of the tumor, as the description says, it is anastomosing hemangioma. It's a H&E diagnosis. Coming to smooth muscle tumors, there are two new entities, EBV associated smooth muscle tumor and the inflammatory leiomyosarcoma. In the skeletal muscle, the ectomesencymoma now moved from peripheral nerve sheath tumor. They thought previously it is more like a neural, but now the muscle markers are positive and molecularly they are more related to skeletal muscle. So they moved to ectomesencymoma into the skeletal muscle tumors. And these rhabdomyosarcomas, they mainly classified as embryonal alveolar pleomorphic and spindle cell and sclerosing. In the new entity of spindle cell and sclerosing, there are three subtypes: congenital spindle cell RMS with VGLL2 change, MyoD1. I mistakenly read it as MODI. Okay, it is not MODI, it is MyoD1, mutant spindle cell sclerosing RMS, and the intraosseous spindle cell RMS. And whenever there is classification like this should have some effect on the patient. For example, these three types, the congenital spindle cell RMS with the VGLL2 change, it is having a favorable diagnosis. Whereas the intraosseous spindle cell rhabdomyosarcoma is a very aggressive tumor. So clinically, they are very different, and molecularly, they are very different. That's why they have put it as a new subtypes. Take a snap of this. So let us see the tumors. It's a 25-year-old female with multiple liver masses. This is a right hepatectomy. 1, 2, 3 tumors are seen. And there's a history of renal transplant. The H&E shows fascicles of spindle cells. It looks like a leiomyoma. Okay. And even IHC, SMA positive, and EBER positive. In addition to SMA, EBER is also positive. And EBER should be negative in a classic spindle cell leiomyoma, isn't that? So that's why this is a EBER-driven tumor in a immunosuppressed people, and that's why it is known as EBV-associated smooth muscle tumor. History of immunosuppression, either HIV or organ transplants or chemotherapy, is very, very essential for this smooth muscle tumor to be named as EBV-associated smooth muscle tumors. They can occur in organs like liver and kidney, and as well as in the soft tissue. This tumor shows eosinophilic spindle cells, but a lot of inflammatory cells are also there, and usually they are present in the extremities, and they are SMA diffusely positive, but there are a lot of inflammatory cells. So that's a new entity named as inflammatory leiomyosarcoma. Without IHC, it's very difficult to differentiate them. Previously, some of them might have been called as inflammatory myofibroblastic tumor or inflammatory malignant fibroschistocytoma. But since SMA is positive, and now it is reclassified as inflammatory leiomyosarcoma. There's another tumor in the peripheral nerve system. Okay, this is one of our case. So I'm lucky enough to get the gross picture. This is a 46-year-old male with a 4.8 centimeter right cervical mass. There is no history of melanoma, because after seeing the gross picture, we asked the history of melanoma. There is no history of melanoma. And microscopically, it shows spindle to epithelioid Schwann cells with a lot of melanin pigments, and they are positive for S100, SOX10, and HMB45. Okay, they look like melanoma, but the location is more peripheral nervous system. And in these cases, the differential diagnosis is melanotic schwannoma, which is a old terminology. The new terminology is malignant melanotic nerve sheath tumor, because when you say schwannoma, it is a benign entity, but these may recur and these may metastasize rarely. That's why it is now known as malignant melanotic nerve sheath tumor. And they have a very classic molecular loss of PRKR1A. Okay, these are all very difficult. Don't try to memorize them. Okay, just keep them in your mind. Just know there is a marker that is lost in malignant melanotic nerve sheath tumor. And when you see 2 or 3 cases, then you can understand by yourself. And remember, one of my mentor, Dr. Jason Hornig, he told, whenever there's a new marker or new name to be remembered, the easiest way is put PRKARIA as your lock in your cell phone. Just keep it for 1 week. Okay, PRKARIA or PRKR1A. And then if you do it for 1 week, you will remember automatically. Next week, you change to another marker. That's one of his ideas to remember the most difficult markers or new names to be remembered. Now you can appreciate more the melanin pigments and the epithelioid cells. So that's a change in peripheral nerve sheath tumors. In the gastrointestinal stromal tumors, there is no terminology change, but the previously mitosis was counted per 10 high power field. Now the mitosis is counted per 5 millimeter square, which is equivalent to 20 to 30 high power field in a standard microscope. But there are a lot of methods to calculate this. In my YouTube video, I have one of the videos where I mentioned how to calculate the mitosis per millimeter square. Please refer that. We covered the renaming in the peripheral nerve sheath tumors. In the uncertain differentiated soft tissue sarcoma, there is a spindle cell neoplasm that showed N-track rearrangement. Okay, and as I told you, without doing this molecular, you cannot brand it as a N-track rearrangement. It's a spindle cell neoplasm, and because of this molecular change, we call it as N-track. Okay, take a photo of this. And they are more common in young boys, males, and they are present in the extremities. They look like fibroblastic tumors, but they are positive for S100 and CD34. Whenever there is a fibroblastic benign appearing tumor that are positive for S100 and CD34, do a pan-track marker, and pan-track marker will be nicely positive in this tumor, and that's why it is named as N-track rearranged spindle cell neoplasm. Why it is important? We have medicine for this target. That's why you have to diagnose these tumors. Coming to the last change in the undifferentiated small round cell sarcoma, previously we put it as Ewing's. Now it is classified as undifferentiated small round cell sarcoma of the bone and soft tissue. And in addition to Ewing's, there are 3 more entities. Round cell sarcoma with the EWSR1 non-ETS fusion. In Ewing sarcoma, it is ETS fusion. Then CAC rearranged sarcoma and sarcoma with BCAR genetic alteration. BCAR genetic alteration sarcomas. Okay. So these 3 tumors, we will be talking more and more of them during this discussion. So by the end of the discussion, you will have a very clear picture of them. Take a selfie of that. And this is the H&V view of all the 4 undifferentiated small blue cell tumors. Okay, it's very difficult to differentiate whether it is Ewing's or CIC arranged or Beaker alterations. You cannot tell them by looking at the H&E. But this thing, I have to thank Dr. Karen Pinto. I took it from her Twitter cartoon, and she made it very nice. There are 4 types, as I told you: the undifferentiated small round cell tumors, Ewing sarcoma, CIC rearranged sarcoma, round cell sarcoma, non-ETS, and sarcoma with the Beaker alteration. Why we have to know them? Because the CIC and non-ETS, they have a poor prognosis. They may not respond to chemotherapy, whereas Ewing's and Beaker alteration, they will have a very good prognosis and they respond to treatment very well. And they have their own molecular signatures and some surrogate markers. There is a new marker called as NKX 2.2. Okay, this marker is positive in Ewing sarcoma. Remember, in Ewing sarcoma, we used to say CD99 fishnet-like positivity, and then FLY1, that nuclear positivity, but those can happen in other tumors also. Whereas in NKX 2.2, it's one of the transcription markers that is positive in the Ewing's sarcoma. That's one member of the small round cell tumor. In CAC rearranged sarcoma, there is another marker called ETV4. We will be seeing the pictures of them. Okay, ETV4. In Beaker arranged, as the name indicates, we have a Beaker marker for Beaker. And then the non-ETS, we don't have a very specific marker, but in addition to NKX 2.2, they will have muscular and neural markers. Okay, desmin myogenin, MyoD1, S100, SOX10 positive. Whenever you see a small cell undifferentiated sarcoma that are positive for muscle markers, neural markers, and NKX 2.2, that belongs to round cell sarcoma, EWS or non-ETS. Take a selfie of this. So that brings the new changes in the WHO and new entities in WHO. How are we doing, Swaroop? Any questions so far?
Sir, in the chat box, one question is there.
Please read out, madam.
From Manoj Kahar. That is, if tumor is received in bits and pieces, how to assess margins?
That's a very good question. And whenever you receive tumor in more than one piece, margin status cannot be assessed. We are not magicians. Okay. So bits and pieces, margin is not. Why they take bits and pieces? It is mainly for the diagnosis. So make a diagnosis and comment margin status cannot be assessed because of the nature of the specimen. Probably they will go depending upon the diagnosis. If it is benign, they will go for local excision. If it is intermediate, they will go for wide local. And if it is malignant, they may go for radical excision. So you don't have to comment the margin status. Super, madam. Any other questions?
Only one question was there.
Super. Manoj, are you happy with the answer? Type happy or unhappy. Any response, madam, from Manoj? No?
Yeah, happy.
Super. So now we are going to the IHC markers of molecular alterations. This is a vast area, okay, and ever improving area. Probably I checked the literature by 8 p.m. Probably there may be some change now because it is 12:30 now in US. So the IHC markers in the soft tissue tumor or any organ, they can be divided into conventional IHC markers and new generation IHC markers. And the conventional IHC markers are lineage specific. They tell whether they are arising from the smooth muscle or skeletal muscle or endothelium. Okay, for example, SOX10, adipose tissue, cartilage and nerve, SMA for smooth muscle. So they are lineage specific markers. Whereas the new generation markers are molecular event specific. Okay, so these are all the new generation markers for soft tissue tumors. Don't worry about them. We will see pictures of all these things. Don't try to memorize them. And you can divide this table into markers that are used in fascicular pattern. Remember the 6 pattern we talked. So whenever you have markers, you divide them into markers that are positive in fascicular pattern tumors. For example, desmoid, beta-catenin, solitary fibrous tumors, STAT6, low-grade fibromyxoid sarcoma, MUC4, or tumors in epithelioid pattern, alveolar soft part sarcoma, TFE3, or tumors in adipose tissue, okay, dedifferentiated liposarcoma where MDM2 or CD4 positive. Take a picture of this. The main concept you have to remember here is they are lineage specific, the conventional markers, and the new generation markers are molecular event specific. These molecular event specific markers can be divided mainly in 6 types. Markers associated with the gene fusion, gene amplification, gene overexpression, inactivation, single nucleotide variant, and the epigenetic where there is aberrant methylation. These are all the 6 major headings under which we will be seeing the surrogate IHC markers. Why they are important? They are very, very important for the personalized treatment where we target the molecular events. Okay, and that's why they are very, very important, and that's why we pathologists should take the driver's seat in helping and guiding the clinicians and the medical oncologists to say what molecular event is there and how they can address that molecular event with the personalized targeted therapies. Okay, so under gene fusion there is a big list. Again, you take a picture of this, we will be seeing a lot of images to cover all these things. Okay, there are 15 molecular markers associated with the gene fusion. So this is a soft tissue mass where you can see small blue cells. Okay, and those small blue cells are having some blood vessels scattered in between them, and this they have metastasized to the lung, and you can see the entrapped bronchial epithelial cells. So these are more small blue cells, and they are positive for BCAR and CCNB3. You know, previously we might have called it as Ewing sarcoma, but since now it is associated with the BCAR and CCNB3, it is a BCAR CCNB3 sarcoma. Whereas this tumor, it's a renal mass and it has lobules of clear cells. Okay, and some of the cells are spindled out with scattered blood vessels. So this is clear cell sarcoma of the kidney. Again, that clear cell sarcoma of the kidney is positive for BCAR. So it's a clear cell sarcoma of the if I told clear cell carcinoma, excuse me, it's a clear cell sarcoma of the kidney. So those are the 2 tumors that are associated with the BCAR. Let us see this composite picture. Here it is self-explanatory in the HNE itself. A lot of desmoplasia with this nest of small blue cells. So this is desmoplastic small blue cell tumor. And these are characteristically positive for Wilms tumor marker, WT1, in the C terminus. Okay, they are nicely nuclear positive. And here the cells are arranged, small blue cells again, the cells are arranged in some of the cells in the center is gone. Okay, so it is trying to show a alveolar pattern, and the PFM.2 is positive in the nuclei. So this is a classic marker for alveolar rhabdomyosarcoma. And this tumor shows some squamous epithelium and may show some respiratory type of epithelium. And this is having very cellular tumor. And those cellular tumor looks like falling under fascicular pattern. Okay, and whenever you do fascicular pattern tumor markers, and this tumor is positive for S100 and SMA. Okay, neural and smooth muscle. So that's why it is known as biphenotypic, and they are characteristically positive for PAX3. So they have definitive diagnostic terminologies because of these immunohistochemical markers that highlight the molecular events. So we already talked about desmoplastic small round cell tumor, alveolar rhabdomyosarcoma, and this biphenotypic sinonasal sarcoma, okay, which are characteristically PAX3 positive with biphenotypic expression of neural and muscular markers. So these are all the markers we covered so far in the gene fusion: CCNB3, BCOR, WT C-terminus, PAX37, FOXO-A1. That's the marker for alveolar rhabdomyosarcoma, and PAX3 for biphenotypic sinonasal sarcoma. Coming to this composite picture, you see the spindle cells with hemangiopericytoma-like pattern. Previously, they are called as hemangiopericytoma, but now you know hemangiopericytoma is gone and it is replaced by solitary fibrous tumor that will have nice STAT6 positive. Okay, so in the H&E you have to give it is a spindle cell tumor or cellular spindle cell tumor with staghorn shaped blood vessels. That's the description in the H&E. And IHC STAT6 positive, you can confidently say it is solitary fibrous tumor. And this picture shows hypo and hypercellular areas, lot of spindle cells, fibroblasts like cells, and that are positive for ALK and ROS1. And most of you might have got the diagnosis. It is inflammatory myofibroblastic tumor with the characteristic ALK and ROS1 expression. This tumor, again, it shows spindle cells, hypercellular tumor, and that are positive for pan-track protein. So this is again a molecular diagnosis or H&E based molecular diagnosis: solitary fibrous tumor, inflammatory myofibroblastic tumor, and N-track rearranged spindle cell neoplasm. This you can see biphasic pattern. Okay, epithelial cells, epithelioid cells, and stromal cells. Here it is more of fascicular pattern spindle cells, and they are positive for SS18 and SSX. Does any one of the attendees want to answer what is the diagnosis of this tumor? Madam, who is the first one who answers, madam? You can read out the name so that we can just clap for that particular person. Anybody typed in the diagnosis?
Sir, is it Manoj Kahar, synovial sarcoma?
Super, Manoj. Good.
And also Ankita Hebbar, synovial sarcoma.
Very
Then
good.
Dr. Nimedita, synovial sarcoma.
Super. So it is a synovial sarcoma. Now it has a very characteristic nuclear marker for SS18, SSX. And how do you remember this? Remember the translocation X18. So this is synovial sarcoma 18 and synovial sarcoma X. Okay. So there is you have to simplify. Some of them may have very logical explanation. Some of them may not have any logical explanation. And those non-logical explanation, you keep it as your key for your mobile phone. And these things X18 you already know, so you don't have to remember. It is synovial sarcoma 18 and synovial sarcoma X. So this is the table that tells what all the tumors we have covered. In the pan-track, the classic example is infantile fibrosarcoma. And I showed you the N-track rearranged spindle cell neoplasm. They are molecularly related. Coming back to this composite picture, this is hypocellular tumor. It shows myxoid areas, and some of the cells show nice intracytoplasmic lumina, like a lobular carcinoma on the breast. But these are all spindle cell tumors. We are talking about soft tissue tumors. And very nicely, they are CAMTA1 positive. And this one looks like a leiomyoma, isn't it? Fascicular pattern. So whatever the pattern, you make the differential diagnosis. And this tumor is positive for FOSB marker. And this is alveolar pattern. And this tumor is positive for TFE3. And this is more like myxoid with a lot of curvilinear blood vessels, some adipose tissue. So H&E wise, this looks like myxoid liposarcoma, and the DDIT3 is positive nicely. Now let us see the diagnosis depending upon these markers. The CAMTA1 is a very good marker for the epithelioid hemangioendothelioma. The FOSB is diagnostic of pseudomyogenic hemangioendothelioma. The vascular markers are also positive. Muscle markers are sometimes positive, but most of the time they are negative. That is why it is known as pseudomyogenic. And FAST-B is a very characteristic marker for pseudomyogenic hemangioendothelioma. TFE3 positivity in alveolar pattern is alveolar soft part sarcoma, and DDIT3 positive is very classic of myxoid liposarcoma. So these are all the markers we covered so far. So now we are done with the fusion markers. So gene fusion, there are 15 markers, you please remember. This composite picture shows a lot of inflammatory cells and a few very large pleomorphic cells. Take the smallest cell and take the largest cell, more than 3 times enlargement. Lot of inflammatory cells. Previously on the H&E, it might have diagnosed as inflammatory MFH, but this CDK4 and the MDM2 are very nicely positive, and it is very classic of dedifferentiated liposarcoma. Okay, and as I told you, it may look like inflammatory MFH, but because of these markers, now they are reclassified into dedifferentiated liposarcoma. These are markers of liposarcoma. So this is one of the amplification marker. In addition to well differentiated and dedifferentiated, it positive in atypical lipomatous tumor, intimal sarcoma arising in the major blood vessels, and surprisingly, they are positive in low-grade central osteosarcoma and paraosteal osteosarcoma. But we are talking about only soft tissue tumor. These are like out of syllabus. There are some bone tumors I may be talking about it, but you just keep it in mind, but they are not today's syllabus. Small blue cell tumor. Okay, previously we called Ewing's. This tumor is positive for NKX2.2, whereas this tumor is positive for ETV4. The NKX2.2 positive marker tumor is Ewing's sarcoma, and ETV4 is a classic marker for CIC rearranged. And remember, the CIC rearranged is having a poor prognosis. In this composite picture, you can see chondroid areas and poorly differentiated areas. And even in H&E, you can make it as a mesenchymal chondrosarcoma. And the NKX 3.1, this is a surprise. I just learned it last month in Twitter. By the way, Twitter is one of the best way to learn pathology. I kindly request all of you to spend 15 to 30 minutes every day in Twitter, where you can learn a lot of new things and you hear it from the horse's mouth, because the research what they are doing, top scientists like Jason Hornick, he will put by himself, today this is the finding we got. So you will be very much updated by following the Twitter. And the you start just following 3 people, and my name is not in that 3 people. The first one is Gerard Garner, second one is Sanjay Magobati Aye, and third is Cameron Mirza. Okay, those are all the 3 people I follow in Twitter, and I follow a lot of other people also. To start with, these 3 people are very good. You can learn a lot of them. NKX 3.1, supposed to be marker of prostatic adenocarcinoma, seems to be a very nice marker for mesenchymal chondrosarcoma. This one shows a lot of sclerosis and small round epithelioid cells. So this is a specific tumor that is positive for MUC4 marker in the cytoplasm. Okay, and this tumor, you all know, this is again a spindle cell hypercellular tumor that is nicely positive membranous and cytoplasmic positivity for DOG1. You all might have got the diagnosis. So NKX 3.1 is marker for a mesenchymal chondrosarcoma, MUC4 for sclerosing epithelioid fibrosarcoma, and DOG1 for GIST. Again, many people make the diagnosis of GIST on H&E. In the H&E, it is one of the differential diagnoses. You need DOG1 or CD117 or platelet-derived growth factor positivity before calling it as or labeling it as GIST. So these are all the markers we covered, and they are all the markers of overexpression. This composite picture, hand mass, these are more like pink cells, large pink cells. Okay, all of them are having large pink cell. Okay, that's one of the concept you have to learn. Large pink cells, some of them we call epithelioid, some of them you may call rhabdoid. Okay, when the nucleus is situated in the center, large pink cell, it is epithelioid. When the nucleus is pushed to the periphery, it is rhabdoid. And I call my PGs and ask them, what is the marker positive in rhabdoid? They will immediately tell desmin. Okay, desmin is negative in rhabdoid. If it is positive, why are you calling rhabdoid? Oid means resembling. They resemble skeletal muscle, but they are cytokeratin positive. Okay, that's why it is called as rhabdoid. Okay, this is a hand mass, and this shows loss of this marker, SMARC-B1, or also known as INI1. And this INI is preserved in the background lymphoid cells and some of the endothelial cells probably, but the tumor cells, they are absent. In this epithelioid tumor, there's a history of thoracic mass, and SMARC-A4 is negative. Again, background cells are positive. In this uterine mass, SMARC-A4 is negative. And in this gastric mass, the SDH-B, okay, succinyl dehydrogenase B, is negative. It is preserved in some of the smooth muscles of the stomach and some of the inflammatory cells or endothelial cells, but the main tumor cells are negative. So these are all inactivation markers. So depending upon that, you give the name. Epithelioid sarcoma, more commonly seen in extremities, INI1 negative or SMARC-B1 negative. Thoracic mass with SMARC-A4 negativity is known as thoracic SMARC-A4 deficient undifferentiated tumor. In the uterine, it is confused with the poorly differentiated endometrioid carcinoma, but it is now renamed as, because of the molecular event, as SMARC-A4 deficient uterine sarcoma. And the gastric mass, which are deficient in SDH2, SDHB, is epithelioid GIST. So as I told you, these gene inactivation tumors are having epithelioid or rhabdoid morphology. So when you have epithelioid and rhabdoid morphology, you put these markers of gene inactivation and you name them accordingly. So these are all the markers of inactivation. The last but one, again, this is out of syllabus. This is a femur, pelvic bone, destructive lesion in the femur. It shows osteoclast like giant cells and many another osteoclast like giant cells and many stromal cells that are malignant looking. You can see a very atypical mitosis. And these tumor cells are positive for a marker called G34W. I think here glycine is replaced, and it is one of the markers of single nucleotide polymorphism, SNP. Okay, so this is so classic for diagnostic of giant cell tumor of the bone. They are negative in all the other giant cell rich bone and soft tissue tumors. Even in giant cell tumor of soft tissue, they are negative. They are very specific for giant cell tumor of the bone. Please remember this, because that's one of the university questions, giant cell rich tumors of bone. All other entities are negative, like aneurysmal bone cyst, parathyroidism, they are all negative. The G34W is positive only in the giant cell tumor of the bone. This is a core biopsy from another epiphyseal lesion. You can see the bone, you can see the cells, and these cells are nicely positive for K36M. Okay, and this is a marker that is diagnostic of chondroblastoma. Okay, yeah. So giant cell tumor of the bone, G34W, and chondroblastoma, K36M. So these are all the single nucleotide variant. And finally, we are coming to a tumor. This is again blood vessel. And these are all fascicular or epithelioid tumor cells. So there's a wide differential diagnosis. And when you do a marker called as H3K27ME3, this I learned from Jason Hornick. Okay, he pronounced it so nicely. I remember them by heart now. H3K27ME3. And I think there's some methylation in H3K27 level. Histone 3 at 27 level undergo methylation. That's what I remember. But you please kindly check. And they are lost in the tumor cells. They are positive in the endothelial cells and some of the inflammatory cells in the background. And when they are lost, it's a very diagnostic of malignant peripheral nerve sheath tumor. Okay, please remember loss of H3K27ME3 in MPNST. That's a aberrant methylation marker that is lost. So that brings the end of all the markers. And there is one concept you have to remember. We saw a lot of translocation associated sarcomas like synovial sarcoma, Ewing sarcoma, and they have uniform cellularity, no pleomorphism, no atypical mitosis. Okay, sometimes they may be mistaken for lymphoma, but lymphoma will have a lot of mitosis. So when you have uniform small blue cells without pleomorphism, without any atypical mitosis, think of translocation associated sarcomas. That brings this slide for you. And these are all the translocation associated small round cell sarcomas. Take a picture of this. So that's the end of this hour's discussion. So the take home message, summary of WHO, please remember the 12 major headings. And please remember this table. How will you differentiate benign and malignant? It's a junction between the tumor and normal. Just whenever there is 2 by 2 table, just remember one. Okay, in benign, it's a well delineated tumor, mildly hypercellular with mild pleomorphism, no necrosis, low mitosis, no atypical mitosis, no apoptosis. That is benign. All the opposite is for malignant. If you try to remember both, you may get confused. So just remember one column. That will help you to remember better. And always follow set of criteria and triple test. Unfortunately, they talk about triple test in breast, where the clinical, radiological, and pathological correlation should be there. It should be followed in all tumors now. As Manoj told, nowadays we are getting more and more fragmented pieces of tiny tumors, and the less the tumor they give, the more the material they want to know. So we have to apply clinical and radiological. And radiological image is very, very important. And I used to tell radiology is part of pathology now. Okay, that's part of gross examination of the specimen. And whenever there is a problem, please call the clinicians. Okay, calling the clinician will solve the problem, or take the clinician to the radiology and have a small tumor board kind of discussion that will bring the diagnosis. And all tumors cannot be classified. Clinical setting and H&E, you have to follow a differential diagnosis, and special techniques, you can use them as a tool to come to a definitive diagnosis. And IHC markers are one of the special techniques, and they are mainly classified into conventional lineage specific and new generation molecular event specific. And they are very important because they help in the targeted therapy. In case of any difficulties, please go back to H&E. Okay, don't make only the diagnosis by IHC markers. So the references is the final part. The first reference is the Ensinger and Weiss soft tissue tumors. This is Dr. Ensinger. This is Dr. Sharon Weiss. This is Dr. John Goldblum. And this is Dr. Andrew Flaw. And these are all the main editors. Why I am putting the pictures? You may see them in conferences or virtual or real conferences. So you can go and talk to them. But when you see Ensinger, you are in a wrong place because he is in the right place now. So the second reference is the Blue Book. Third is Google Images. Only 10% of them are my images. All the others, I took it from other references in Google Images. Pathology outlines, single, if you are able to read only one source, please read pathology outlines. Many of the conventional professors, pathology professors may be angry with me, but that's one of a beautiful site. And again, I am not financially connected. By referring that, I am not getting any money. And the fifth and sixth, they are the articles that formed the backbone of today's discussion. Okay, the 2020, the first one is by Choi et al. 2020 WHO classification, selected changes and new entities, and all the immunohistochemical markers I talked about associated with molecular events are from Anderson et al.'s paper. Okay, they are recently 2021 papers, both of them. And take a selfie of this because you may be interested in these papers, and I think I have given it in my handout also. So these are all the people we have to thank, because these are all the people who sat together and put their knowledge and come up with the 5th edition of the Blue Book. You can see Jason Hornig there, Andrew Flop is there, Christopher Fletcher is there, Dr. Mahul Amin, one of a proud Indian pathologist, is there. Rest of the people, I don't know, I think this is Dr. Thompson Lester from the ENT. Okay, so we thank all these people also for putting a nice book for us. So with that, I want to end this discussion. The only way to do great work is to love what you do. That's what from my mentor, Steve Jobs. Thanks a lot and have an awesome time. Madam, are there any questions, madam?
Sir, there are no questions. There are few appreciations telling that it was very super. Thank you, sir. And excellent lecture. 2 good short of words to express my gratitude and thanks. This is from Manoj Kahar. And Shakti, he tells it is super, sir.
Manoj Kahar is very active. Where is he from? Manoj, can you unmute yourself, introduce yourself? And I kindly request other people, if you are not asking question, I am going to ask questions. I can see the names here. I see Dr. Tanka madam. Thank you, madam, for attending this.
Manoj is from Navsari, South, small town he has written.
Congratulations, Dr. Rajendran. It was so wonderful.
Thank you, madam. Thank you for coming and attending.
Yeah, thank you. Thank you.
Nivedita, I think I know Nivedita. What is the learning point from this 1 hour discussion, ma? What's the time, madam? How are we doing time wise? It's 12:55. I have up to 1:30. Is it, madam? What's the time now there?
10:45, sir.
So what time I'm supposed to finish, madam? 11:45.
10:45, sir. 10:45.
No, madam. The next talk, next one.
Slide seminar is between 9:45 to 10:45.
Oh, I'm supposed to finish it by 10:45.
Yes, sir. Yes, sir.
How long I am left with now?
Half an hour, sir.
Oh, okay. I can finish it in half an hour. Just one more. Nivedita, what is your learning point from today's thing, ma? Unmute yourself and talk.
Good morning, sir.
One learning point.
So today I have learned that in WHO 2020 there are like 23 updates, sir.
Super. Thank you. Vidya, what is the learning
Thank you,
today?
sir.
Vidya is not talking to me. Harendra Kumar. I'm just randomly picking up people. Since you are not asking, I am picking up you. Just tell one learning point. This is more like what you understood so far.
Good morning, sir.
Yes.
I am Arendra Kumar.
Yes.
Yeah, nice to hear your voice and you are after a long time, your lecture also was good. Yeah, it is just a refreshing class for me to update the ISC markers, especially on substitute tumors, sir.
Super. Super, sir. Last one. Ankita Giridhar. I think that's the one who diagnosed synovial sarcoma, isn't it, madam?
Ankita Hebbar, I think.
Hebbar. This is another Ankita, I think.
Yeah, Ankita
Any
Hebbar.
one of the Ankitas, can you unmute yourself and tell me one learning point? In the meantime, I will just stop sharing and I will go to my next one. Next talk.
So it was a very good presentation. I learned about the new molecular classification, so many new molecular markers.
You tell me one more. I just want to know what
especially
is your,
the cyst and Beaker rearranged round cell tumors.
Super. Super. Thank you. So I will go to slide seminar again. I don't know how many of you have seen the slides. I think I have circulated a PowerPoint presentation. Ankita, have you seen it?
Yes, sir.
Super. It's the same presentation. I don't know why I am showing the same presentation. I will get my next one. Just give me 1 minute. All of you, please stand up, stretch your hands, stretch your legs, move the neck right and left, do some exercise. I will promise you to finish the slide seminar 10 slides in 30 minutes. Super. There we go. Share the screen, desktop, share it. Kalani madam, after today's thing, whenever the recorded video is available, please email it to me. I
Yeah,
want
sure,
to
sir. Sure,
put it
sir.
in my YouTube.
Yeah,
Just,
we'll
1,
send
2,
it
3.
across to your email as attachment.
Yes, thank you. We'll hide the floating thing. So can you see the slide seminar slide, madam? Any madam?
Sir, it's visible.
Super. So case number 1, 20-year female, 3 centimeter nodule of the left thigh, noted for the first 2 weeks. Madam, you can read out some of the name, madam. We will just give 10 seconds for them to answer. If they know, they can answer. And I kindly request all of you to freely participate. Okay. This is hyperview, hypo and hypercellular areas, tissue culture like appearance. What is the diagnosis? Only one diagnosis is correct. Any answer, madam, there?
Anybody? Any of the postgraduates?
Okay. Because
Sir,
of the
Ankita
time.
Hebbar, she has answered as nodular fasciitis, and Shakti
Super,
as
Ankita.
nodular fasciitis.
Super.
And
The
Mahesh
first
yeah.
one will, the name will be read. Others, because of the time constraint, we won't be able to read, but apologies. Okay. Madam, we will read out the first, only the first name, madam, because of the time constraint.
Yeah, okay.
So grossly, it's a tan white gray myxoid. This is the unfixed tissue, and this is the fixed tissue. It's very, looks like relatively circumscribed with no capsule. And zonation effect is there, hypercellular center with a hypercellular periphery with the immature fibroblasts and myofibroblasts. And this classic feathery tissue culture like growth pattern you can see very nicely. That is very classic of nodular fasciitis. So the another one feature I want to show is extravasated RBCs. Okay. And the funniest thing which I learned from Dr. Elizabeth Montgomery, there is no hemosiderin-laden macrophages. Usually the RBCs will have a lot of hemosiderin-laden macrophages, isn't it? Here there is no hemosiderin-laden macrophages. So the extravasated RBCs, tissue culture like fibroblasts and zonation, they are the features of nodular fasciitis. I am not going to read through all these theory, but wherever it is, I will ask you to take a photo of it. Please take a photo of this. So we'll go to case number 2, 52-year-old carpenter. This is a very interesting case with a 3 centimeter lesion in the left shin. So he is putting a lot of pressure in the left shin because of this work. Okay, very pale looking ischemic areas, and in high power, very malignant looking or ganglion looking cells. Okay, and there is no mitosis. So one of the concepts you have to remember, mitosis and atypia has to be seen together. When you see only mitosis, it's a regenerative mitosis. When you see only atypia, it is degenerative atypia. So here there is a lot of atypia which is degenerative because there is no mitosis. So what is the diagnosis?
Again, Ankita Hebbar, proliferative fasciitis.
Oh, ischemic fasciitis. Okay, they are all related, but here there's a lot of ischemia, a lot of necrosis, and there's a history of pressure on that area. Usually, these are seen in wheelchair-bound people in the ischial tuberosities, where there will be a lot of pressure in that area, and because of that history and because of the ischemic change, it is more of ischemic fasciitis. So these are all the other pictures. I think probably you have to take a picture of this, because this is the differential diagnosis. All sarcomas come into the differential diagnosis, but in ischemic fasciitis, no mitosis. And the proliferative fasciitis, since Ankita mentioned, I want to read this. They are not at pressure points, whereas ischemic fasciitis is at the pressure points. Case number 3. Large ectatic blood vessel. Okay, this is a thigh mass in 46-year-old male. Lot of blood vessels, and this blood vessel is ectatic, and there's a lot of cells. In the high power, you can see a lot of pleomorphism. If Tanga madam is there, she may remember we had one case together. So you have to combine all these. Okay, these are more pleomorphic cells with the angiectatic blood vessels. So, and there's a lot of hyalinization also going on there. So what is the diagnosis? So it's a self-explanatory. It is pleomorphic hyalinizing angiectatic tumor. So these are all the features of this tumor: mitotically inactive tumor with large bizarre cells with the prominent ectatic blood vessels. So immunohistochemically, they don't have a very specific marker, and no molecular even so far. So now we are moving to case 4, 3 centimeter posterior cervical mass with a 70-year-old male. Very nice picture, lot of adipose tissue. Whenever you see adipose tissue, think in terms of lipomatous tumors, variants of lipoma or intermediate grade lipoma or liposarcoma. Here, these are many Tauton type of giant cells, and some of them are very pleomorphic, isn't it? Very pleomorphic, multinucleated type or Titan type of giant cells. Very nice picture. And what is the diagnosis?
Manoj Kahar, pleomorphic lipoma he tells.
Super, Manoj. Okay, immunohistochemically CD34 positive. Remember, lipoma is S100 positive, but pleomorphic lipoma and spindle cell lipoma, they will be S100 negative and CD34 positive. So diagnosis is pleomorphic lipoma. And these are all the theory behind it. You can take a snap of this. Now we are moving to case number 5. There are 2 areas seen. These are loose myxoid areas with the curvilinear blood vessels, and these are cellular round blue cells with some myxoid areas. So myxoid areas with the classic curvilinear blood vessels, and these are small blue cells that we saw in the previous slide. So what's the diagnosis? So the diagnosis is, before diagnosis, IHC S100 is positive in some of them.
Shakti, he puts it as myxoid liposarcoma.
Yeah, it's a high grade. Okay, because when you see these small blue cells, more than 5%, more than 5% of these small blue cells, it's a high grade. Previously, we used to call it as round cell liposarcoma. Now, round cell liposarcoma is molecularly related with the myxoid liposarcoma. That's why they put it under that category. And when the round cell tumor is more than 5%, it falls under high grade myxoid liposarcoma. These are all the theory behind it. Please take a snap of this. And these are various forms of lipoblast. And another question the PGs asked me, where to look for the lipoblast? Look for the lipoblast in the periphery as well as around the blood vessels. Okay, those are all the areas where there will be more lipoblast. Here you can see even this low power near the periphery, there's a lot of lipoblast there. So this is the differential diagnosis. So the differential diagnosis depends upon, is it only lipomatous areas, is it only myxoid areas, or is it small round blue cell tumors? The DD differs depending upon what you are looking. So take a picture of this. Types of liposarcoma now with well-differentiated myxoid pleomorphic, and the new entity is myxoid pleomorphic and dedifferentiated. Well-differentiated lipoma, the subtypes, we have 3 subtypes. Lipoma-like, well-differentiated. These are all the tumors that look like lipoma because of the anatomic location. They are known as liposarcoma. For example, in the retroperitoneum or in the deep soft tissue of the extremities like thigh or buttock. Inflammatory liposarcoma, we already saw an example of that, and sclerosing liposarcoma. Myxoid liposarcoma, as I told you, if it is more than 5% of small blue cells, we call it as high grade. Pleomorphic liposarcoma, the one of the subtype is epithelioid liposarcoma. And the dedifferentiated liposarcoma itself is divided into low grade and high grade now. Usually the high grade will have heterologous component, predominantly myogenic. The high-grade myxoid liposarcoma and high-grade dedifferentiated liposarcoma, especially with the myogenic differentiation, along with the pleomorphic and the myxoid pleomorphic, they have a very bad prognosis. Take a picture of that. So case number 6, this is again another self-explanatory picture. Lot of sclerosis, lot of epithelioid cells that are looking like arranged like spinal cords, spinal bodies. Okay, so Indian pile arrangement with the hyalinized areas. So this is sclerosing. You can see the sclerosis and the Indian pile arrangement, sclerosing epithelioid fibrosarcoma. Okay, so that is the diagnosis. What is the marker associated with the sclerosing epithelioid fibrosarcoma? Any one of the attendees? We talked about it in the molecular markers or IHC surrogate markers.
MUC4, they have given MUC4. Sir.
Super, MUC4. Okay, and remember low-grade fibromyxoid sarcoma. Very good. Low-grade fibromyxoid sarcoma also MUC4 positive. They are related. See, in another 10 years' time, all these H&E diagnoses will go off. All the molecularly related. For example, MUC4 positive tumors. We may call it subtypes or low-grade fibromyxoid sarcoma and sclerosing epithelioid fibrosarcoma. So take a picture of this, and I have mentioned here MUC4 is positive. All others are non-specific. Okay, and that's the list of differential diagnosis. Case number 7, again self-explanatory. Lot of desmoplasia, small blue cells. Okay, so desmoplastic small blue cell tumor. And this is a very confused tumor because these small blue cells take the markers of skeletal muscle, take the markers of neuroendocrine, take the markers of keratin, and take the marker of WT1. And WT1 C terminus is the molecular event that takes place in this tumor. Okay, high power showing the sclerosis and small blue cells. And the diagnosis is, I already told you the diagnosis. It's a desmoplastic small round cell tumor. This is the criteria: nests and cores of cells with a desmoplastic stroma. The stroma may be edematous, and the cells may palisade in the periphery, and central degeneration may look like alveolar, but here it is more solid. Okay, sometimes it may be confused with alveolar pattern tumors whenever there is central necrosis and the clearing of the necrosis. These are theory behind them. Please take a picture of this. And again, remember that CD99 we used to tell fishnet-like pattern, but now WT1 replaces all the markers. But as I told you, they are positive for cytokeratin, positive for desmin, positive for CD56, positive for NSC. So I call them as exam going tumor. They are very confused. Okay, immunohistochemically. WT1 is the marker now. This is the differential diagnosis. The chimeric EWS WT1 fusion product is the WT1 C terminal protein that is positive. Translocation 1122. These are all the things they ask you in the exam. Case number 8, 38-year-old male with a 6 cm swelling near the ankle. You can see some epithelioid cells, some fascicular pattern cells. These are probably bone dust. And here some epithelioid cells and some fascicular pattern. And these cells, they look like mitosis, but they are mast cells. Okay, and mast cells one of the clue for this tumor. Okay, So let us see who got the diagnosis. What's the diagnosis? Mast cell, very commonly seen in synovial sarcoma. It will be seen in any other sarcoma also. H&E is TLE1 positive and BCL2 Y-mentin and focal cytokeratin. TLE1 is supposed to be a very specific marker for synovial sarcoma, probably last year or 2-3 years before. Now it is, what is the current marker for synovial sarcoma? Any one of you? Anybody answered, madam? If nobody answered, that means I have not discussed them well.
Sir, SSX18 by Shakti.
Super Shakti. And you include SSX also. Okay, SS18-SSX.
Dr. Nivedita has given out and Dr. Mahesh.
Super. So this
Dr.
is synovial sarcoma. This is the diagnostic criteria: epithelioid, spindle cells. This is the gross picture with a lot of hemorrhage and necrosis. These are all the theory behind it. Please take a picture of this. And this is more about monophasic pattern. This is one of the synovial sarcoma, one of the translocation sarcoma. It's very difficult to see a picture. I think I got it just show it to them. It can be seen, but usually it is no pleomorphism, no increased mitosis. Okay, so for translocation associated sarcomas, this is SS18-SSX. Super. And this is the differential diagnosis. Again, depends upon whether it is biphasic, monophasic spindle cell or monophasic polydifferentiated areas. So the DD depends upon what is the pattern. For example, fibrosarcoma you cannot have in the differential diagnosis when there is a biphasic tumor. Biphasic tumor should have carcinoma, polydifferentiated or sarcomatoid carcinoma, malignant peripheral nerve sheath tumor, and diffuse type of tenosynovial giant cell tumor, where you can see two types of cells. Take a picture of this. Case number 9, 4.8 centimeter mass in the shoulder of a 19-year-old boy. Nicely positive for PAS diastase. What's your diagnosis? I think I gave it as peanut. Peanut, the terminology is not used now. Ewing sarcoma. And this is CD99, which is supposed to be positive like a couple of years or 1 decade before. It's a very classic of Ewing sarcoma. So the diagnosis is Ewing sarcoma. And please remember, PAS diastase is one of these special stains we have to remember when they ask in the exam in India. So FLI1 and 99 old markers. Okay, what is the new marker now for Ewing sarcoma? Anybody? Vidya or Ankita? NKX 2.2. Okay, this is the theory behind it. Take a picture of this.
By Emmanuel.
Okay. So these are all the theory behind it. We used to tell fish net is P net. Okay, but the P net is gone. CD99 fish net is also gone. It is Ewing's now with the NKX 2.2. Take a picture of this. So small blue cell sarcoma, I told you there are 4 members. Okay, it can be NKX 2.2 positive, MyoD1 and SOX10 positive, ETV4 positive, or BCOR positive. Depending upon these markers, they are divided into Ewing, round cell sarcoma, EWS or non-ETS, CAC rearranged sarcoma, and the sarcoma with BCOR alteration. Take a picture of this, because if you see all the 4 tumors in one with the IHCs, it's very easy to remember. Otherwise, it looks very confusing. And you have to remember the CIC and I think BCOR are associated with, no, the non-ETS and the CIC associated with the bad prognosis, whereas Ewing and BCOR alteration, they have good prognosis. Last case, 20-month girl in a mass in the left calf, This is a very characteristic picture, and this is what known as alveolar pattern. The central cells are lost. That's why I asked the PGs, when do you call lung? They tell alveolar spaces. No, if you tell alveolar spaces as lung, this also you can tell lung. To say it as lung, you have to see the airway. No airway in this tumor, so it is not lung. So what is the differential diagnosis? Some areas are looking solid, some areas are looking like this alveolar pattern. The diagnosis is alveolar rhabdomyosarcoma. Myogenin is positive. What is the marker positive in alveolar rhabdomyosarcoma? The molecular surrogate marker. Anybody? So this is the theory behind it. Please take a picture of this. Myogenin and desmin. And this is the molecular event, okay? PAX FOXO1. Yes, so it is PFM2. Okay, that's the marker. PFM2. Great. Yes.
Shrijan.
Yeah. Types of rhabdomyosarcoma: embryonal, alveolar, pleomorphic, spindle cell or sclerosing. The embryonal has typical bourgeoid and anaplastic type. Alveolar has classic and solid type, that is positive for PFM2. Only alveolar rhabdomyosarcoma is positive for PFM2, not the other types. In spindle cell or sclerosing, I already told 3 subtypes. Okay, that those associated with gene fusions in alveolar rhabdomyosarcoma, they have bad prognosis. Pleomorphic carry a bad prognosis, and MyoD1 carry a bad prognosis. And I want to end my slide seminar by showing this beautiful picture from internet. These are all the cross striations and rhabdomyoblasts, okay, that you have to look for in rhabdomyosarcoma. And the take-home message: there are some reactive lesions stimulating sarcoma, and there are some soft tissue tumors with nuclear atypia. For example, pleomorphic lipoma, pleomorphic leiomyoma. These are all degenerative atypia because mitosis won't be there. Okay, so please remember these conditions because they are commonly mistaken for sarcoma. Again, please use set of criteria: radiology, clinical and pathological correlation, and phone calls in difficult cases. Thank you very much and have a lovely time. I think I am finishing at 8. What time, madam? I think I took
On
5
time,
minutes.
sir. On time only. 2 minutes you have taken extra. That's all. No problem.
Super. Any questions, madam?
In the chat box, no questions, sir. Tanka madam has replied as excellent session. And Dr. Mahesh, nice session. Thanks for sharing wonderful slides.
Super. Thank you, madam. Thank you very much. I thank the team in Kolar, headed
so
by
much, sir.
Dr. Kalani, madam, and Swaroop for interacting with me for all the technical trials and other things. And I see Lanjavar sir there. So again, I know Lanjavar sir because we are from Taramani, sir. I came down to Grand Medical College for autopsy. You may not remember me. I think it's in the year 1989.
88, 89.
Yeah. Sunil Badwe and there are Balakrishna Shanai. They're also there at that time.
Okay,
So,
good. Long back.
Yes. Super, sir. You look like same, sir. Only color I think you colored your hair white, I think. Otherwise, no change. Super. Thank you very much, madam.
Thank you very much, sir, for your time and excellent presentation. We'll catch up later.
Super. Thank you. Bye.
Bye, sir. So, good morning, Lanjavar, sir.
Good morning.
Thank you, sir. We shall now move on to our second session, which will be on Do We Still Need Clinical Autopsy by Dr. D.N. Lanjavar. And as chairpersons of this session, I invite Dr. M.N. Harendra Kumar, Professor, Department of Pathology, and Dr. Srinivas Reddy, Professor and HOD, Department of Forensic Medicine, to commence the session by introducing our esteemed speaker.
Good morning, sir.
Good morning.
I'm Dr. Lanjavar, sir. So myself, a forensic person. Focusing on.
I have to bring my screen. Can you give me 1 minute?
Yes, sir. Yes, sir.
Yeah.
In the description part. Sir, let me introduce, sir, Dr. Lanjavar, sir. Sir is a professor and head of the Department of Pathology, Gujarat Adani Institute of Medical Sciences, who is Gujarat. Sir is formerly professor and head at Grand Medical College, Mumbai. Teaching experience is 44 years. Main interest is autopsy pathology and infectious disease pathology. Sir is pioneering in work on autopsy pathology in HIV/AIDS cases. Formerly president of Indian Academy of Pathology and Microbiologist and dean of Indian College of Pathologists. Invited speaker in various international and national conference and international and national CMEs. Sir has a credit of over 70 papers in international and national journals. Sir has written a book on autopsy practices. I over to you, sir. Sir is talking a title of Do We Still Need the Clinical Autopsy? Am I audible, sir? Sir, unmute yourself, sir, please.
Okay. Good morning, everyone.
Good morning, sir.
And organizers of the CME, Dr. Kalyani, Dr. Swarup Raj, Dr. Suprita, distinguished faculties, and participant. This is the institute where I am working today.
Yes, sir.
Gujarat Adani Institute of Medical Sciences. This is college campus. This is hospital campus, nursing campus, and student and resident hostel. 2001 was a bad scenario for this Kutch district, where there was an earthquake and this entire hospital was collapsed during that earthquake. 711 casualties, deaths, including patients, doctors, technicians, and nurses, occurred in that period. And after that, this institute was established in 2009, which has an undergraduate as well as postgraduate program. Today I am speaking to you about the subject do we still need a clinical autopsy? And before I proceed to this subject, I wish to know about the audience. What is their idea about this? The first question is, what is the number of clinical autopsies individually performed and reported by you? And then a given number of autopsies, 0 to 50 and above. And the answers I'm looking at, none of you have done a single autopsy. I don't know whether you have observed or not. So, with this understanding, I proceed for the presentation. Next slide. Yeah. And therefore, I have made a very simple plan of my talk. In the beginning, a brief introduction will be given, where I will be informing you how I was involved with the autopsies. There will be discussion on contribution of autopsy, value of autopsy in cardiac, CNS, and neonates, cancer research through autopsy, role of autopsy in epidemics and pandemic, and in the end, I will be discussing with you the Indian scenario of clinical autopsy. Then there will be summarizing and concluding events. Two photographs are shown to you. One is GMC Aurangabad, 1979 to 2nd June 1985, where I was postgraduate student and I was faculty. Government Medical College Aurangabad is a famous place because in the vicinity of Aurangabad, world famous caves of Ellora and Ajanta are located. On 3rd June, I was transferred on promotion to a Grant Government Medical College, Mumbai. We was established in 1845. Dance in pathology has worked in this institute. Several pioneering investigations are carried out there. And clinical autopsy was a strong point in Grand Medical College, Mumbai. So I was coming from this institute where autopsies were not looked that much carefully to this institute where autopsies were the heart of everyone. So how did I start? I started silently observing the departmental activities. And 6 months later, January 21 to February 7, 1986, tragedy struck Sir J.J. Hospital, Mumbai. This tragedy is about 14 unnatural deaths in 18 days. And they were produced and caused because someone wanted to earn more money. So these were because of ugly facets of the human mind and apathy towards human life. What happened to these 14 cases? Clinically, they had no problem related to genitourinary system. None had a kidney disease. They were either admitted in a neurosurgery or neurology or ophthalmology for some tumor or hemorrhage, which produce increased intracranial tension and increased intraocular tension. For this, all of them received glycerine. Common drug given to them was glycerine, 1-2 days followed by glycerine. All patients developed acute renal failure and died. I told you it was for small amount of money. This is because this glycerine was adulterated with diethylene glycol. Some pharma company had did this to earn more money. This was investigated by Justice Lentin. And the words of this commission are very important. They did not ask to be born. All those who died, they did not ask to be born. They did not choose to die. They died as they had lived quietly and in poverty. Heartbreaking statements were given by this Justice Lentin. This episode was investigated by my guru and head of the department, Dr. Vagolikar, who unfolded the tragedy. And this tragedy was unfolded because of clinical postmortems. These were the findings in the kidney. Halves of both kidney are shown to you. Significant lesion is identified in a cortex of both kidneys. And the entire cortex shows coagulative necrosis. This is what is called as bilateral renal cortical necrosis. And if you look at this phenomena, bilateral renal cortical necrosis, it is very common problem with obstetrics. Either pregnancy-induced hypertension or PPH, intrauterine fetal death, or placental abruption, and DIC. An autopsy, it is reported in 0.19% cases. And therefore, those pathologists who are involved with the autopsy work, they will see 1 or 2 cases of renal cortical necrosis in their lifetime. And this scenario was different. In 18 days, 14 cases of bilateral renal cortical necrosis were identified. That stimulated the investigation. The glycerin of that company was analyzed. It shows diethylene glycol. The glycerin was fed to the experimental animals, rabbits and mice. They also show similar renal cortical necrosis. So from all angles, it was proved that diethylene glycol was the agent. How this helped? 14 autopsies saved life of thousands of people. Remember this. Because the glycerin of that company, which was distributed in entire Maharashtra, it was banned for use. So several deaths were prevented by one such investigation. This investigation had a great impact on my mind. Therefore, I decided, let me work in the field of autopsy, where many people are reluctant to work. And therefore, I worked for more than 22 years in my autopsy room. Arrange the flow of autopsy work from the beginning to the end. At least participant must answer this. They have not done any autopsy. They must have seen forensic autopsies during their training. The question is, arrange the flow of autopsy work from the beginning to the end. 5 options are there: reporting histopathology and concluding causes of death, starting of prospectus work, processing tissue for histopathology, starting of DNS work, and handing over corpse to the family. So this is a poll. None of you have answered this? Okay, no problem. And this is the answer. Starting of Danner work. Danner, this is the answer to that. Danner is a servant to the dead body. Accept the body, then works of prosector start, dissect the body. After dissection, handing over of the corpse to the family, processing tissue for histopathology, reporting histopathology, and concluding cause of death. This is most important. Just performing a postmortem is not enough. You have to report that, conclude the cause of death, and do clinico-pathological correlation. This completes the postmortem. Let us now look the contributions of world leaders to the autopsy. Several great pathologists I have shown you. They all work mostly from Europe. William Osler was from Montreal, Canada, and Alan Webb. This is important for you. Kolkata, Indian Empire. Substantial work has been done in India during those periods. Look at their profession. They all were physicians. They used to perform on the patients to whom they have treated, to know the cause of death and to know the effect of treatment which they have given. I wish to inform you about this Alan Webb. In 1848, he published a book, Pathologia Indica, or the Anatomy of Indian Diseases. It is based on autopsy studies from corpuses which were available in the entire Indian Empire, very big empire, which included in that time Pakistan, Sri Lanka, Singapore, Aden, and so on. And the pathology of Indian diseases was described in this book. Let us look at the wordings of Giovanni Battista, the founder of pathologic anatomy. He writes, physicians who have done or seen many autopsies have learned at least to mistrust their diagnosis. But the others who do not confront themselves with the often discouraging findings of autopsies live in the clouds of invade illusion. Therefore, the question is, who needs the clinical autopsy or pathological autopsy? Another quiz, mark the most appropriate answer. 5 options are there. A physician, B pathologist, C health institutes, family of corpuses, and all of the above. Quiz master, are there any answers? Anyhow, everyone needs autopsy. Physician is learning from them. Pathologist is learning pathology. Health institutes understands the quality of their hospital. Families knows why the patient have died. Have they done enough to save the patient? Is there a genetic problem? Is there an infectious problem? So answer to this, all of the above. What are the benefits of autopsy? Autopsies have led to more than 87 discoveries. This is record up to 1996. There are 2 articles which describe the discoveries made through post-mortem studies. And most importantly, it doesn't end here 1996. The process of discovery has continued to the present day. I'm going to show you that, and will continue in future. Therefore, clinical autopsies are important. Why do pathologists need autopsy? Because pathologists learn how to identify lesion. In surgical pathology, you know everything. You know history, you know age, you know site, you know clinical diagnosis. In autopsy, you have to identify the lesion from the entire body. And it is not only identifying the lesion, you have to interpret the lesion. That is a training you get during postmortem. We understand the extent of disease, extent of disease progression. Autopsy helps in detection of new morphology in old diseases. And the most importantly, autopsy detects new disease or unrecognized disease. Okay, 2% are given, all of the above. Great, very nice. Now, identification and interpretation of I'm going to show you this one by one. This is a story of a 3-year-old boy with diarrhea, passing up large worms in feces, round worms, vomiting of worm, crawling up worms through nostrils, terminally developed respiratory distress and died. Pediatricians were sure that roundworms has obstructed the respiratory tract. That is how child has died. But still, it was a practice in Grand Medical College to do autopsy, postmortem was performed. The intestine, small intestine showing large number of roundworms. The organ block, trachea, lungs, heart, liver, spleen. It shows large collection of roundworms in a subcapsular location. Roundworms were seen in a peritoneal cavity. They were seen moving on the surface of the spleen. So now this is the quiz for you for this picture. The roundworms were seen perforating the liver. It showed abscesses on the surface of the spleen, and bunch were seen over here. The quiz is, one of the following is route of entry of the adult roundworms in the liver. Select the appropriate answer. Peritoneal cavity, A, B is the portal vein, C is the duodenum, and D is hepatic artery. And peritoneal cavity, 17% responded, 1. Portal vein, 11. Duodenum, 3. Hepatic artery, 2. Okay. And the answer is through the duodenum by entering in the ampulla of Vetter and then through biliary tract. This is the open up duodenum. This is the ampulla of Vetter. And the bunch of roundworm is entering. This causing obstruction of a common bile duct. This common bile duct is protruding, greenish in color. And when roundworm enters from intestine into the ampulla of Vetter, it carries along with them bacteria. This causes cholangitis, cholangitic abscesses, the rupture, and through that you can see coming up of the roundworm. Okay, great effort. The second help of clinical autopsy is to detect new morphology in old diseases. And to this is the example. Female, 25 years, presented with cough, fever, and expectoration since 3 months. Autopsy findings showed this feature. Spleen shows numerous biliary tubercles. On the contrary, female, 25 years, severe weight loss, HIV reacted. Her spleen shows this picture. Few small tubercles. Many of these tubercles, they have joined together to form big abscesses. This is what is called as change in morphology of old diseases or identification of new morphology. If a smear from this material is collected and stained with Gill-Nielsen stain, it will show teeming colonies of tubercle bacilli. Such lesions are very common and they are produced because of immune deficiency. Autopsies uncover unusual structure involvement. And this is the story of a 52-year-old male. Pain in a left hip joint, inability to walk since 2 months, swelling of left limb from going to the toe 2 months, dyspnea on exertion 1 month, no history of trauma or chronic disease. MRI showed fracture, head and neck of the femur. Doppler study did not show any evidence of deep vein thrombosis. It showed absence of blood flow in anterior and posterior tibial veins. Synovial and soft tissue biopsies was performed from left limb. Patient became acutely breathless on 8th day of hospitalization and expired a possibility of pulmonary embolism was suspected and a clinical postmortem was requested. This is what it is. In the postmortem examination, the first thing which you have to rule out is the clinical diagnosis. Clinical diagnosis was pulmonary embolism. Pulmonary embolism was not seen. All organs except heart were normal. There was a cardiomegaly. Biventricular cardiomegaly was there. Right-sided heart chamber was normal. Left-sided heart chamber was normal, except small dilatation. Histology showed these features. Number one, pericardial vessels thickened. Intramyocardial vessels thickened. They showed homogeneous pink color material, and the lumen of the blood vessels was reduced. These are the lumen of intramyocardial coronary arteries. PAS stain was positive. Congruent stain was positive. Mitral wall showed this homogeneous pink color material. The blood vessels of the lung showed similar features. Blood vessels of the kidney, blood vessels of GIT, pancreas showed similar features. And blood vessels of the synovial biopsy also showed similar features. It was positive for congruent. The birefringence is positive, and electron microscopy shows branching filaments of amyloidosis. Unusual localization is what is called as blood vessel. This is called as angiocentric deposition of amyloidosis. Therefore, sudden death due to amyloidosis of intramural corollaries in the patients of amyloidosis of hip joint, amyloidosis was not suspected clinically. It was identified only at a postmortem. That is the value of postmortem. Only one report of angiocentric amyloidosis is described in Indian literature. Demonstration of unusual localization, vascular amyloidosis is important because clinical manifestation of amyloidosis depends on the structure involved. The most common presentation of amyloidosis is renal failure or hepatomegaly or splenomegaly, which shows either the large spleen or sago-spleen. But in this case, vascular amyloidosis produce myocardial infarction. The importance of autopsy in medicine is described in these academic pathology article 2019. And this article is written by a pathologist who was constantly involved with autopsy practices. What they say, congenital heart disease. Today's advancement in a diagnosis and surgical correction of congenital heart disease is due to in-depth characterization of anatomic defects in autopsy by Maud Abbott, Maurice Liu, Jess Edward. In India, this work and similar work was done by Dr. Suman Kinare, former head of the Department of Pathology, said GS Medical College, Mumbai, and KM Hospital, Mumbai. She did excellent work in cardiovascular and pulmonary pathology. Some articles comes like this. Our autopsy is absolute. And they themselves then conclude in several autopsy studies that autopsy study results demonstrated 45% of undiagnosed cause discovered at autopsy. This is in an era where high technology was developed. CT was developed, USG was developed, MRI was developed. And therefore, this article concludes that old-fashioned, low-technology autopsies can uncover many important diagnoses missed by modern high-technology medicine. Reviving the autopsy as diagnostic error reduction tool. What this paper says, errors are estimated to occur in 10 to 15% of all diagnoses. 10 to 15% is not a small amount of patients. This can lead to significant harm and cost. This is about autopsy, but what about living patient? A poll of patients was conducted in USA found that 1 of 6 people had personally experienced medical errors related to misdiagnosis, which is a concern of a patient. Therefore, also, autopsy remains a powerful tool for the study of diagnostic errors. These articles have also established the utility. It has shown major discrepancies in 23%, minor discrepancies in 32% cases. And the major discrepancies occurred in common diagnoses, myocardial infarction, pulmonary embolism, and pneumonia. Let us look into these 2 articles which are published recently, 2018 and 2021. One is published in a American Heart Association journal, The Circulation, and another Association of European Cardiovascular Pathology. This entire Circulation article was devoted to the role of autopsy in sudden cardiac death. And in addition to autopsy, they emphasize genetic testing on autopsy material. Same thing was emphasized by Association of European Cardiovascular Pathology. Sudden cardiac death. 80% of deaths are caused by coronary artery disease. 10 to 15% cardiomyopathies. 5 to 10% of death are caused by inherited cardiac disorders, such as coronary artery anomalies or cardiac channelopathies. These deaths cannot be diagnosed even after complete autopsy study because grossly and microscopically the hearts are perfectly normal. And therefore they have advocated, these both journals, Cardiovascular Pathology Journal, that the causes of sudden cardiac death, which remain unidentified after complete autopsy and microscopy and toxicology examination, is called as sudden arrhythmic death syndrome. It is a genetic heart disease that causes sudden death in young people that apparently look healthy. The molecular testing in these cases play a critical role in identifying sudden cardiac death in victims of structurally normal heart. Let us look into the utility of autopsy in central nervous system diseases. Brain banks. We have one brain bank in Bangalore, NIMANS. Scientific program of research where brain of the patients diagnosed with neurological disorders are gathered and studied. These brains are obtained after autopsy. to reveal more insight into the causes of diseases such as schizophrenia, Alzheimer's disease, and Parkinson's disease. About these diseases, very little information is available. And therefore, also autopsies are required. What does blood bank do? Brain bank do? Collection and preservation of brains to do research into the human CNS diseases. Incidence of brain diseases increases with aging of the population. And therefore, major source of brain bank is clinical autopsy. If clinical autopsies are not performed, what we are going to learn in a brain bank? The alternative solution to this is that the clinical autopsies, since clinical autopsies are decreasing, new strategy should be brain donor program and obtaining brain from medical legal cases. The value of autopsy in neonates in 21st century. They have conducted autopsies in infants and demonstrated additional findings in 48% of the cases. And therefore, these results emphasize that autopsy has important role in NIU setting and show that conventional autopsy could probably not be completely substituted by postmortem MRI examination. Several diseases in children, they are researched through postmortem examination. Two such examples are mucoviscidosis. It was diagnosed only on a postmortem study. Pathologic lesions in children with AIDS. A great study carried out by Indian pathologist Dr. Vijay Joshi in America. He described this. Such findings can be identified only in a postmortem study. Utility of autopsies in cancer research. It determines the extent of metastatic disease that we have known. Our understanding of route of spread of malignancy, carcinoma and sarcoma is developed through postmortem study. But postmortem studies are also important to understand molecular mechanism of treatment-resistant cancer. There you need autopsy. To understand tumor biology for development of targeted therapies. And autopsies are important to determine population-based cancer epidemiology. Now, in this respect, I think there is one quiz for you. The first report of incidence of primary cancer as inferred from autopsy is described in one of the following institute. Mark the most appropriate answer. Answer state the institute and in the bracket the year of establishment of the institute is given. Option A is Kolkata Medical College, Kolkata, 1835. B. Armed Forces Medical College, Pune, 1948-1962. Grand Government Medical College, JJ Hospital, 1845. St. GS Medical College and KEM, Mumbai, 1926. Tata Memorial Hospital, Mumbai, 1941, 1952. Yeah, answer to the quiz. And there are response from many participants. Some say 20% say Kolkata Medical College, 10% say Armed Forces, 40% say Grand Government Medical College, 20% St. GS, 10% Tata Memorial Hospital. Okay, let us see the result. This is the result. Grand Government Medical College and Sir J.J. Hospital, Mumbai. This college was established in 1845. Coroner's Act was implemented in 1871. And from 1872, clinical and medical postmortem were started in this institute. From 1872, the autopsy records are well preserved till today. These autopsy records are not only preserved, but information from this is also published. And this is the answer. The incidence of primary carcinoma in India as inferred from postmortem records of 50 years, from 1877 to 1926. It was done by Dr. Kharpure PV in the Indian Medical Gazette, 1927. Dr. Kharpure PV is eminent pathology in India and pioneer in starting poliomyelitis vaccination in this country. This paper states that in these 50 years, only 36 cases of cancers were identified, which comprise of 14 liver, 13 stomach, 7 pancreas, and 2 gallbladder. This old information is important. We know what was happening earlier. 50 years after that, Dr. Kharpure published another article in 1948. From 1927 to 1946, total number of cancer increased threefold. Carcinoma liver was identified in 8. And therefore, old records are important because old records tell us which diseases were prevalent. Current records will tell us which are the vanishing diseases or which are the new or emerging diseases. Role of autopsies in pandemics. I have given you example of 4 pandemics from 1346 to current pandemic of COVID-19. You know, death tolls in them, most of them epidemics are worldwide. Bubonic plague was restricted to Europe, Asia, and North America. All this epidemic provided pathology of newly emerging infections, autopsies in all of them. And the most important, the remains of 1918 Spanish influenza virus were investigated in 2005 by Institute of Armed Forces Institute, by Armed Forces Institute of Pathology USA. It was the outstanding contribution of AFIP. And in 2005, genome sequencing of entire influenza virus was completed from recovered remains of few victims. That is the utility of postmortem examination. This provided breakthrough to study virus in vitro and in vivo to better understand the properties, pathogenicities, transmissibilities, and elicitation of host response with a major implication for future prevention of subsequent influenza epidemics. That is the value of autopsy. And now let us move to our own investigation. Journey with AIDS pathology. The investigation, which was carried out by me at the Grand Medical College, Mumbai, and the first day occurred on 20th June 1988. that India woke up due to first death of AIDS patient in Mumbai. The findings of this first death made us to think, to work in this direction. We decided to do more autopsies. It was like walking through the less traveled road. But this journey led to a new beginning. We learned pathology of AIDS from our own patients. And we did not only learn, we taught people through CMEs, through conferences, through our published literature. People have learned pathology of AIDS in India from this autopsy material. That is the value of clinical postmortem. This is that first clinical postmortem, 35-year-old commercial sex worker, lung cut surface of lung is shown, and capsular surface of both kidneys are shown. All organs were perfectly normal. Grossly visible pathology was not seen in any of the organ. But when we looked at histology, we saw museum of microorganisms. What is that museum? Cryptococci, 18 organ systems, cytomegalovirus, lung and adrenal, tuberculosis of lung, hilar lymph nodes, and tuberculosis of spleen. Such type of diseases and infections, none of us had witnessed earlier in autopsy study as well as in a surgical pathology study. Emergence of CNS toxoplasmosis due to AIDS. 1991, 35-year-old commercial female. She presented with epilepsy and brain showed this necrotizing lesion. Histology showed this true cyst and pseudocyst of Toxoplasma gondii containing bluish organism in them. Prior to 1991, no case of adult CNS toxoplasmosis was documented in Indian literature. Then why this happened? Because CNS toxoplasmosis, a toxoplasma produces a disease whenever there is immune deficiency. Fetus suffers because immunity is not developed. Woman doesn't suffer because she had a good immunity. In AIDS, immune deficiency came and therefore reactivation of old focus of CNS toxoplasmosis occurred and therefore toxoplasmosis was seen. In initial 10-15 cases, clinical diagnosis of CNS disease were tuberculoma or tuberculosis. And in all of them, CNS toxoplasmosis were identified. No tuberculosis was identified. This is what we discussed with our clinician, and they started diagnosing CNS toxoplasmosis, treating the cases. These cases were responding very well to the treatment. Literature search on HIV/AIDS, 2 initial articles, one published from Los Angeles, demonstrated pneumocystic carina. Another case of Kaposi's sarcoma and pneumocystic carina. Autopsy report, they concluded that many opportunistic infection and neoplasm in these 2 reports were underdiagnosed during life. And they suggested that by complete autopsy examination, pathologists will continue to increase understanding of this new syndrome. And this is what has happened. We did several autopsies. This is the largest report, 236. And then we have published organ-specific pathologies like liver, pulmonary pathology, CNS, GIT, heart. And this literature was helpful to all the pathologists. The conclusion of our series showed that infectious disease is a predominant cause of death. This is where we differ from a literature in Europe and America. We have seen high prevalence of tuberculosis, less prevalence of pneumocystis carinogenosi and Kaposi sarcoma. And we have seen emergence of new diseases like toxoplasmosis and Isosporabili. Isosporabili was the first time documented by us in a fecal specimen. Let us look into the role of autopsies in COVID-19. The first report is this. On COVID-19, it was published in February 20, and it was on surgical biopsy specimen in 2 resected lung cancers. Both these patients had acquired COVID in hospital, and the adjoining lung parenchyma, adjoining to the cancer, it showed this picture, diffuse alveolar damage. And they labeled it as coronavirus pneumonia. The clinical manifestation of the patients which were seen in entire globe, they did not manifest like pneumonia, and therefore the entire globe started questioning editorials came, review articles came, and the editor said, COVID-19 death, are we sure it is pneumonia? Please, autopsy, autopsy, autopsy. And for this, no autopsies were happening. No autopsies on COVID-19 deaths. A missed opportunity and lockdown of science. That is the value of clinical postmortem. Despite the active appeal to perform autopsies, only few institutes responded, and these are those institutes: Germany, USA, Italy, China, Switzerland, Australia, and 57 autopsies were performed. And this is a systematic review of postmortem findings in COVID-19 patients. I am focusing your attention to 2 authors, Swati Satturwar, our student at Grand Medical College, Mumbai, who is currently pathologist in USA, and Mary Fox. She's the author of this paper, but at the end of this paper, they acknowledge her. The authors dedicate this publication to their late co-author, Dr. Mary Fox, a professor of pathology and director of autopsy and neuropathology at Mount Sinai Hospital, New York. She died of a heart attack on November 15, 2020 in New York at the age of 66 years. But before death, she had done a significant contribution for the human being. She is Mary Fox. Early in the COVID-19 pandemic, as clinicians began to report patients with confusion, seizures, loss of taste, smell, Mary Fox decided to examine the brain. And she identified small strokes and infarcts and very minor chronic inflammatory around the blood vessel. She also found evidence that the virus had entered into the endothelial cells of the brain. All of these studies were critical to understanding what was originally identified as a respiratory disease was a much more complex disease affecting the other cell type. This led to a new kind of clinical interventions, including a clinical trial on anticoagulation strategies for COVID-19 patients. Her great contribution we acknowledge in this presentation. And these are the organs showing pulmonary embolism, thromboembolic phenomena in a lung, and the histology shows all these thrombi in the blood vessels. So thrombosis was the most common manifestation just found at autopsy that was responsible for significant death. Heart showing infarct, and this infarcted area, and this thrombi in the blood vessels of the brain. These are all thrombi in infarction. American Journal of Surgical Pathology, 2021, writes, autopsy remains a gold standard to understand pathogenesis and pathology of new and emerging diseases. Pathogenesis help in improved patient management in pandemic and epidemic. Information acquired from autopsies is useful for the management and treatment of patients in the entire globe. And all these statements have been proved in the pandemic of COVID-19. Let us now look at the Indian scenario of COVID-19. Only 57 autopsies were performed. AIIMS Bhopal 23 forensic autopsies. Rajkot, Gujarat 33 clinical plus medical level autopsies. PGI Chandigarh 2 postmortem biopsies. KEM 1 forensic autopsy. And in all those cases, lung shows diffuse alveolar damage, microthrombi in CNS and other organs. Status of clinical autopsies in India. This is now important for all of us to know what is happening in our country. Total number of medical colleges in our country as of today are 605, which includes 284 government medical colleges and 289 private medical colleges. 32 medical colleges in deemed university, 17 AIIMS, postgraduate institutes of 64, and only 10 institutes of the 605, they have clinical autopsy program. No clinical autopsies are performed in 595 medical colleges. The question is how our students are going to learn, how our students and residents and then faculties will advocate for the clinical postmortem or request for the clinical postmortem when they do not know in the ground reality that the utility of postmortem, clinical postmortem is so much. With this, I conclude my lecture. I thank everyone for patient listening. And once again, thank Dr. Kalyani, Swarupraj, Suprita for this invitation. Thank you very much.
Thank you, sir. Any question from the audience? Nobody is answering. I congratulate Dr. D.N. Lanjavar, sir, for your excellent presentation with the evidence-based how autopsy is important. And last slide, it is really heart-touching that what the colleges are doing. Without that, we can't learn or we can't proceed with that. With the central government making so many rules to make the research as a multidisciplinary approach, as well as present scenario of epidemic and pandemic, and the increase in incidence of non-communicable diseases. What we are going to teach to our students, because there is no clinical autopsies available, even with the modern technology, whatever the biomarkers they use, there still autopsy is needed. That's what my opinion. What do you feel, sir?
Yeah, we require autopsies. We have so many Medical Council of India and National Medical Council. They write down on the paper that minimum 20 autopsies should be done in each institute.
Yes, sir.
But nobody inquires about that. And without inquiry, these colleges get green signal of starting medical colleges. And it is not only starting medical college, it's starting postgraduate education in pathology. So this is one, it is one thing about education, but what about the quality of our hospital? Quality of our hospital is judged if 20% of their deaths are autopsied, then we know what is the standard of autopsy. but it is happening, and we cannot prevent that.
Yes, it is true, sir. Unless we make our request, our NMC through all medical colleges or with administrators, whether the principal or directors, to make that
Absolutely.
at least a clinical autopsy, the death which occurs, at least 10% of this should be done mandatorily.
Yeah.
Then only
Yeah.
the things will make
Then
it.
only it will happen. Yeah. All medical colleges have to respond. Particularly government medical colleges have to respond. When government will respond simultaneously, private will also respond. So it is a job of pathologists as well as physicians. Physicians also have to know that they are also learning from this.
Definitely, sir. Any question from the audiences? Thank you, sir, once again for your excellent presentations. We will take a note of that. We will try to push the ideas and also for the future pathologists. Thank you once again, sir.
Okay, bye.
Thank you, sir, for sharing your insight and knowledge and enlightening us. We now have a very interesting session on art of writing book in this era of technology. And our speaker for this session is Dr. Ramdas Nayak. And this session will be chaired by Dr. T.N. Suresh and Dr. Manjula K., Professors, Department of Pathology. So I request sir and ma'am to kindly initiate the session.
Good morning. It's our privilege to have Dr. Ramdas Nayak as a speaker for today's National CME. Sir is graduated from Mysore Medical College, Karnataka, and completed his post-graduation in pathology from Kasturba Medical College, Mangalore. Sir is at present working as a professor and head of Department of Pathology, Enopaya Medical College, Mangalore. In his illustrious teaching career of 40 years, Sir was head of Department of Pathology, Kasturba Medical College, Mangalore, Manipal Academy of Higher Education, Karnataka. He has published over 83 scientific papers in both national as well as international journals. Sir serves as examiner for both postgraduate and undergraduate examinations in several universities. Sir has worked as project officer for development of an Atlas of Cancer in India, a project conducted by Indian Council of Medical Research, sponsored by WHO. Sir was the editorial committee member of South Asia edition of British Medical Council Journal. Sir has authored 10 books entitled Essentials in Hematology and Clinical Pathology, Textbook of Pathology and Genetics for Nurses, Rapid Review of Hematology, Exam, Preparatory Manual for Graduates, Pathology, Exam Preparatory Manual for Undergraduates, Pathology for Dental Students, Textbook of Pathology for BPT students, a Textbook of Pathology for Allied Health Science, Histopathology Techniques and their Management, Manual of Transfusion Medicine, and Review for Postgraduates Pathology, General Pathology. Sir has secured Good Teacher Award and 8 times Best Audio Visual Award in Kasturba Medical College, Mangalore. Over to you, sir.
Thank you, madam. Can you hear me?
Yes, sir.
Can you see the screen?
Yes, sir.
Can you see the full screen?
Not yet, sir. Not yet. It's still.
Yeah. Hello. Sorry.
Not it, sir.
Okay. Good afternoon, everybody. This is not pathology what I am talking. It is the art of writing book in this era of technology. British writer Stephen Fry told successful authors are those who know just how difficult it is to write a book.
Sir, it is not in presentation
Hello, can you
mode.
hear me?
Sir, it is not in presentation mode.
Not in presentation mode. Last time you told, no, what is that should be?
Duplicate, sir. Slide sharing option, duplicate.
It is in the top. Is it?
Sir, sir, now yes, sir. Top, you should go to slide display settings. So display settings on the top.
Not sure.
Internet disconnect.
Hello, where is it?
Sir, on the top, sir, display settings.
No, it is not so there.
You are seeing full screen, sir.
Pardon.
Sir, are you able to see the full screen, sir, or you're getting that next slide?
Side, I am getting the screen.
Correct, sir. Sir, on top, you have to choose display settings.
और भी कुछ कल अच्छा होती हो.
Hello. It's not
Sir,
there. Display setting.
That on the top, you will have those three options: show taskbar, display settings, and end slideshow.
No, it is not there.
Sir, you're connected to the displays, huh? Large display. If you disconnect it also, it will work. Now on your laptop screen, you're able to see the setting. Huh?
Can you see now?
We are seeing the presentation mode, sir, where the next slide is also seen.
Is it now seen, the next slide?
It is seen, sir.
Is it okay then?
Sir, can you just stop the presentation mode and come back again to it? Press escape and come back.
Now?
No, sir, it's still the same. You can close the PowerPoint and yes, sir. Now you can start. Yes, sir, now it's on.
It's okay. Can you see the screen? Hello?
Yes, sir, we are able to see the screen. Sir. Now it's perfect.
So British writer Stephen Fry told, successful authors are those who know just how difficult to write a book. I'm not telling that writing a book is difficult. First, you should learn how to publish scientific articles. That is how you know how to read and write. And nothing is difficult till you think it is difficult. Similarly, writing a textbook is not difficult unless you attempt to do it. So what are the different steps in writing book? I will go in according to this order. The beginning, how to start a book, why you want to write a book, what you want to write, and how you want to write the book. Then after your beginning of the writing the book, staying motivated. Next is finishing the book work, publishing the book, and marketing. These are the different steps involved in writing a book. And in between, I will concentrate on the present era, what are the advantages as well as the disadvantages. So beginning, first is, are you interested in writing a book? Some of you may say, yes, I want to write a book. You write a book by deciding first why you are going to write a book, what you are going to write, and how you are going to write. Why you want to write a book? Can anybody tell why you want to write a book? There are many diverse motivations. One of the reasons is you are dissatisfied with the textbooks that are available. Second is these books don't meet student needs. Third is you may believe that you have a different and better way of presenting material to students. Significant expertise in an area of knowledge and deliver it to students or consultant pathologists may be another reason. Wants to make a difference through writing. By your book, it makes a difference to the readers. Many goals should be to advance student learning. So main advantage of the writing a book is your book should make the student to advance in learning. Don't write a book if you just want to make money. You won't find much return on your time and efforts toward the project. So don't write a book because I want to make money. More money can be earned like going to Gulf countries, starting a lab. And another thing is to become famous. You want to become famous by writing a book? How many of you know that I have written 10 books? Maybe hardly about 1 to 2%. So you won't be famous. I went to one of the college as an examiner. I asked which book you read. Fortunately, they told, we read your exam preparatory manual for undergraduates. And I asked, who is the author? They told my name, but they didn't recognize me. So you won't be famous by writing a book. Neither others will recognize you. Your book is considered as your with name. They don't recognize you. So you want to become famous, you can become famous with other methods. Then after why you want to write a book, next is what to write. And third is how to write. We will come to what to write. Decide on the subject, like whether you want to write a textbook, or in case of pathology, whether you want to write histopathology, hematology, cytology, or you want to write a book for consultant pathologist, or a specific system where you are dealing with, or it may be the techniques in pathology, which may include hematology, histopathology, and cytology techniques. If it is a textbook, determine your subject and the students. I mean, it is the pathology subject, whether you want to it for BDS student, MBBS students, or allied health science students, for whom you are writing a book, and how you want to structure your book. Decide on the grade level of readers. Please remember, you should consider to reach a middle class level UG or PG student, not a top level. Your aim is to make a middle class level to attain the top level, or a low level student to reach the middle class level. Consider which areas are underserved and require a book. Don't select a book which is very popular book and you want to compete with that book. Wherever there is no good book available, you try to write a book on that subject. Does your book fill this area in the market? Suppose there are no books, for example, there is no book for BSc MLT. You want to write them, or there is some technique like other allied subjects. You want to write a book, then you write. If there is a very popular book, it is not worth competing with that book, which is very popular. What is needed to write a book? Check what comparable books exist in the market. Define your unique selling point. After you decide what is the point which makes your book unique for selling purpose, and what makes your textbook special compared to the existing books, and what does it offer that no other book offers. Talk to the fellow authors who have already published the books and get feedback from them. You talk to the authors because they know the difficulties. They have undergone all the difficulties in writing a book. Time required for writing. It's a long time. Please remember, writing a textbook it can take a very long time. Sometimes it will be years between the time you start to draft the book and the time it comes to the print. So textbook writing is definitely not for everyone. It is like a cricket match. All cannot be a wicket keeper, all cannot be bowler, all cannot be batsman. So if it is your time is there, enough time is there, then you can think of writing a book. What is the time required? Are you prepared to spend this amount of time, long amount of time each day for writing a book? Are you passionate about the subject? Are you interested in the subject and you want to give the subject to the undergraduate or postgraduate so that they can easily understand? Then you can think of writing a book. Your main goal should be advanced student learning. When the student reads your book, the goal should be the student advanced learning should be met with. Assume that your reader has no knowledge of the subject. Don't think that he knows it. Assume that the reader or the student has no knowledge about your subject. Focus on the students who will read your book, and assume your reader is not academically oriented. Some of the dull students may not be interested in pathology and how to teach them. So that is very important in the book. Assume your reader is not a professional and doesn't want to be like in your profession. How your book is different from your competitors, this is also important before you start writing. Cover much the same stuff everyone covers. There is nothing called a book. Textbook should cover all the topics which are meant for undergraduates. So you are also covering the same stuff, but the presentation is different. Like you get a chaya in a 5-star hotel, same tea you get outside in a small shop. Tea is same, but the presentation is different. So how are you different from others? Select, then after you have decided to write a book, you have to select a publisher or you can publish yourself. This I will talk little later. Next is how to write. All of you may be interested in knowing how to write a book. I have already told why to write a book and what to write. Next is how to write a book. The hard part of writing a book isn't getting published, but the hardest part is writer's job is sitting down to write. It is actually the writing which is very important, and book don't just write themselves after all. You have to invest everything you have into creating an important piece of work. Getting started is you have to start writing. You have to start somewhere. Whenever there is start, then only there is beginning. If you don't start, there is nothing called end of this. So most overlooked step in the process is starting writing. I have seen so many I have encouraged to write the book. Some have started writing 1 or 2 chapters. They stopped after that. Some have written half of the book and they have stopped. So it is very important that this process should continue. Writing is a process. You write a sentence, then a paragraph, then if you are lucky, an entire chapter. This is how the process starts. When the process begins, then only it can end. Writing happens in bits and in pieces. You cannot write a book within 1 month. You cannot write a book within a year. It may require 2 years depending on the number of pages. So it happens in bits and pieces. After you have selected to write a book, design an outline, come up with an idea for how will you structure the book, how many chapters will be included in the book, how will you divide the specific topics between the chapters. If there are several chapters, how will you divide, and whether the chapters are independent from each other, or will the student need to read one before they can move on to the next. Suppose there is a connection between the first chapter and second chapter or subsequent chapter, it is also should be borne in mind. Determine the most important material to include. You won't be able to include everything in a piece of information relating to the subject in a book. It will become a postgraduate book. So it is very important to know whether you are writing to an undergraduate or a postgraduate. So most important is the content, depending on whether it is an undergraduate or postgraduate. How will your textbooks helps in examination that student need to take during the year? And students will judge your book whether it is useful during his examination. Knowledge is okay. Another is how he can score good marks in the examination. Draft each chapter, decide where you need to add more material or cut down on the length. You may be very interested because I feel I am interested in renal pathology. That doesn't mean that I have to include all in the renal system, which we are including in the undergraduate book. Of course, for a postgraduate book, the more details may be required. So what are the steps in writing? The daily goal. Set a daily goal. We are always busy. Get up an hour or 2 early in the morning. Write a page or 2. You don't need to write a lot. As far as I am concerned, I cannot write more than 2 pages per day. And the minimum is half a page. And if there is a diagram to be drawn, I take full day for drawing a diagram. You just need to write often, and setting a daily goal will give you something to aim for. So keep a daily aim that I have to write this much for this day. Make it small and attainable so that you can hit your goal each day and start building momentum. Set a time to work on your book every day. Please remember, this is very important. And consistency makes creativity easier. You need a daily deadline to do your work. That is how you will write a book. Feel free to take a day off if you want, but I won't take a day off. If you feel free, take a day off. Never let a deadline pass. Setting a daily deadline and regular writing time will ensure that you can write a better book. So place. Write in the same place every time. Why? It just needs to be different from where do you do other activities. Make your writing location a specific space so that when you see that space, you remember that I have to write for today. It should remind you of your commitment to finish the book. And there are so many people who have started the work, they have stopped in between because there is no motivation. Create a set writing schedule that includes a regular habit of writing your book. Some say 4 to 6 a.m. It is the best time to write. Some write only Monday to Thursday, Monday to Saturday, and Sunday they want to relax. So avoid writing erratically in large chunks of time. You are writing on a Sunday, erratically on one Sunday morning, another Sunday afternoon, another Sunday night. So don't be having erratic way of writing. If you are working under the publisher deadline, do not postpone. Give yourself plenty of time to complete the task at the earliest. Set weekly goals in the months leading up your deadlines. So when you start the work, mention this week I am completing this, this month I am going to complete this work. In textbook writing, the focus always has to be on the student learning. Look at the student who is reading your book and define every term clearly. Don't think the student knows all the terms. So define every term clearly, and every point has to be clearly made to the student. Avoid long words and long sentences. When we look at the long sentences, we don't feel like reading. So long words and long sentences decreases the readability of the text. Use the simplest words and sentences possible. Use italics and bolding liberally to emphasize the important terminologies. One cannot provide too many details. Suppose you are writing for undergraduate, don't provide too many details. Students are not interested in knowing much of the details. They are interested mainly in understanding how to write in the examination. Be selective in detail as it can detract from the big story. It is important to know what is to be included and what is not to be included. This is your decision and your expertise considered, because you know as a teacher what the student should know and what the student need not know. One needs to be creative, but it is very important that creativity helps the students to understand the subject. And now coming to the present era of technology, the use in writing is, technology is increasingly making the life of an author more easier. Consider in the olden days, they used to write in a paper, then suppose there is correction, they had to write in another paper, that is taken now. Now because of computers are available, you can easily write a book. Writing or typing is easier with Microsoft Word or similar programs. It is not difficult. Tables and box can be easily inserted into the text in Microsoft Word, and bullets of various designs can be used whichever you like, and spell and grammar checking. This is very important because when you do the spell and grammar checking, sometimes the computer doesn't know you are a medical man and it gives an alternative which is totally not connected with us. I tell you one of the example is when I wrote miliary tuberculosis, the alternative what the computer used to give is military. The meaning is totally different. When I wrote neutrophil, it was giving an alternative as neutrophil. So that meaning is totally different. So be careful when do the spell and grammar checking. The most textbooks now come in the e-form. This is the era of technology. Most of the students now like e-book form. Some are only available in this format, while others also have a hard copy. You should consider how will you adapt your textbook for a digital audience nowadays, because the digital is becoming more and more important compared to the reading the book. You will include a corresponding website for the textbook where student can find practice questions. You can create a website where student can log in and practice questions. Computer or hardware crash. This is one of the dangerous part. Once I applied, in the beginning, I had written a very nice chapter, but unfortunately the computer hardware got crashed and I had to write again. Please remember, to avoid that, you have a copy either in the external hard drive or in the Google Drive, so that whatever work you have done is not lost. Always keep a backup. Incorporate helpful visuals. When you write a book, it is very important that you don't want to put your students to sleep if it is a monotonous way of presenting the word. Huge blocks of text might be difficult for students to process. You will need to visually break up the page, include a lot of tables, boxes, or figures and pictures, or flow charts, or other graphics which will illustrate the points, and that makes students to understand better. This is what very important, not just writing the text. It is important to include tables, boxes, figures, flow charts, which will make the students understand better. So what is the era of technology in writing? Table and boxes can be easily inserted into the text. Flow charts can be easily drawn. Bullets of various designs can be used. Spell checking and grammar checking is easier. Graphic designs. There is a CorelDRAW program for graphic design, which I took almost 6 months to learn this CorelDRAW for my book. And of course, there is Paint and other graphic designs are also available. For any outside images or graphics that you include, make sure that you have permission to include them in your book. You could be sued for copyright infringement if you don't. Success is a book that lasts for 3 or so years and sells well enough to generate a next edition. So be prepared. When you write a book, it is not the end. It is only the first edition is the beginning. So every 3 to 5 years, you have to bring out another edition. Success is knowing that many students will understand the field as a result of your efforts. What is the success? If the student has come to know the subject in an easier way, that is your success. Some of them may even change the career plans as a result of your efforts by reading your book. Technology, as I have already told, plagiarism. What is plagiarism? Is presenting someone else's work or ideas as your own with or without their consent by incorporating into your work without full acknowledgement. Softwares are available for plagiarism check. After you complete the work, how to publish? When publishing a book, you can either work with a traditional textbook press or you can self-publish. With a traditional textbook press or can self-publish, there is a difference. What is traditional textbook press? Looking for a textbook publisher? Traditional presses for medical textbook include JP Brothers, which I am following, ARIA, CBS, Errant, and APC, etc. are available. Publishing with the traditional textbook press, look up the contact information on the publisher's website. They will generally have a guidelines for how to submit a book proposal or get in touch with the editor. In order to get approved, you will need to prove the published proposal to the publisher. Make sure when you give a book proposal, clearly explain the content and why it is important for and what is your target audience. These are the things which publisher wants to know. If you are a full-time academics, you will be approached by the publisher to your college. Alternatively, publishers' representatives often visit universities and arrange face-to-face meeting with academics to discuss about publishing or writing a book. As an author, you can take this opportunity to see whether a publisher would be interested in your proposed textbook. What is the advantage of traditional press? If you publish with a traditional press, they will manage the book. Disadvantage of traditional press is you will have to sell the copyright of your work to the publisher, and you will no longer have the rights over the material once you sign a contract with them. Self-publishing means we only publish, we only sell it. Advantage of self-publishing is you can generally retain your rights to the material, and it is often more profitable than compared to with the publisher. Disadvantage of self-publishing is harder to spread the word about your textbook to college and university. In case of a publisher, they only will go to the different colleges. They will only do the canvas of your work and devise a marketing strategy on your own if you are publishing yourself. iBooks. You could also make textbooks available for purchase through iBooks textbooks platform or through a personal website. After you have completed the proposal and written the book, the publisher will send you the proof. The proofreading is very, very important because it should be thoroughly checked. Just like I told in my book, the publisher wrote miliary tuberculosis as military tuberculosis, neutrophil as neutrophil. So you should be very, very careful. You can be little careless when you write, but when it is proofreading, because it is finally going to be printed, be careful. Then marketing the book, you can sell to your students. If you are a teacher, your students are the most obvious customer base. Explain student how your textbook is different from the available textbook. Complimentary copies to your colleagues or other pathologists you can give. And suppose there is a conference, market it at the professional events because conference occurs every year, and speak to the organizer about having a booth where you can sell your book to your interested colleagues. Of course, when you go to the publisher, they only have a booth where they have all the published books. If there are popular bloggers in your field, you can also make them to write comment on your book. After the book is written or printed, get strong review. Teachers and students' review is very, very important. This will add to your credibility as an author and to the value of the textbook. Please think that any comment which is good or bad, take it positively. The technology for connecting with the users. Once a writer has got his or a book published, technology is now also becoming increasingly used to connect with the readers. For example, Facebook. Whenever my book is published, I usually announce it in the Facebook, or it is the WhatsApp group, Twitter, Telegram, email, or using Amazon Kindles, where my book, one of the book is available in Amazon Kindle. So people like that rather than a hard copy. Website and application allows writers to participate in live discussion, that is question and answers. Website and apps allows writers to participate in live question and answer session with their readers. and writers of self-help books can create and earn money from learning courses. When book is considered as excellent, after you have written the book, your book is released, when you consider the book is excellent, a textbook is successful if the student without any knowledge learn a great deal from it. After reading it, they should become excited about the field whether they originally were not. Greatest satisfaction is when thousands of students have learned about a subject because of your efforts. See, this is my exam preparatory manual. If you go to Amazon, see the feedback what students have given. One of the students has given a very good feedback, and this is how he has written. The book is actually pretty good. The content is good as Robbins, but this book has an upper hand in terms of organizing the information and infrequent repetition. High yield points are depicted in separated boxes and quick revisions, which makes the revision time efficient. By far, the experience of pathology with this book has been amazing. If you are willing to give a try, then go for it. Got the book on time and in excellent shape. Another person is also written and with the one photograph. And most important is here is one student. I am an average student but passed with flying colors. This indicates your book is very popular. Then embrace failure. Not that what you write a book should be or need to be successful always. Embrace failure. As you approach the end of this project, know that this will be hard and you will be the most certainly mess up. Just be okay with failing and give yourself grace. Very important, failure is the beginning of the success. Reason why most never finish their books. I told some of my colleagues whom I encourage, out of 10, only 2 have come with the subject. So 2 have come with the book, and some have stopped either after one chapter or half chapter, or some have never come up. Why? Author quit. You started writing a book, but never completed it. You got stuck and didn't know how to finish. You completed your manuscript, but didn't know what to do after that. Worse said, you wrote a book, but no publisher cared about that book publishing. Nobody bought it or read it. After you are published, nobody bought it or read it. Reason why I wrote my book is the purpose is it is to give the knowledge. When I was a professor in Kasturba Medical College, Mangalore, students used to ask me, what is the advantages of the books that are available? Problem is, I was not happy. So I went to Antigua, that is West Indies. There I came to know what student want and what student doesn't want. So I started writing book about 12 years back, and that writing has changed my life. It helped me clarify my thinking, find my calling as an author, and has provided an opportunity to make an impact on the world. The disadvantages of technology, textbook sales have been on the downswing, partly due to the used book market that are available, which you call second-hand books, partly because students are reading less. Present-day students, you hardly see reading a hard copy. They read the books which are e-books. And Xeroxing. If the book is very expensive, they Xerox. As the textbook sales decline, publishers raise prices to compensate for lost revenue and in turn make students more reluctant to purchase when the book cost is higher. And this becomes a vicious circle. So the textbook sale comes down by down. Moreover, one can find pirated site on the internet that makes the book available for free. You may not believe, most of the books are available free in the internet. Do you think they will read about your book? Recently, one of the persons showed me the pirated version, which is a violation of copyright laws. He showed me that your book is in the internet, available free. But I told, I wrote not for making money. If somebody is getting benefit out of reading this pirated ebook, it doesn't matter for me. I'm not taking money with me, just like Jayalalitha didn't take all the money with her. So please remember, it is not the money which you are going to take, but the wishes or the best wishes of the students who got good marks in the examination. To summarize, write a book if you have time and patience. Students are your customers, and customer satisfaction is your motto. Write regularly using simple language that can be understood by average students. Break the monotony by using tables, boxes, flowcharts, pictures, graphs, etc. Use a good publisher like JP Publisher, New Delhi. Why I selected is a very reasonable person, and I know the director or the owner of that is Mr. JP Vij. He's a very good friend of mine, and he called today morning also. When are you giving the review of pathology for postgraduates? That is the systemic pathology. So he encourages me to write every day. I get up early and start writing. Proofreading is very important and takes long time. After book is published, take feedback from the users. Use the present technology for every aspect of book writing. Writing in present era is more easier than before. Use of Microsoft Word, CorelDRAW, Paint or other tools for writing and drawings. Available technology make easier to market the book and get feedback. Disadvantages of technology is xeroxing the book. Pirated versions are easily available free in the internet. Hard drive crash is one of the things which you should keep in mind. So always have a backup. I thank Dr. Kalyani, the professor and HOD of Sri Devaraja's Medical College, and Swarup Raj, Suprita, Harendra Kumar, Suresh, Subhashis Das, Shilpa, and all other organizing committee members from Sri Devaraja's Medical College, a constituent college of Sri Devaraja's Academy of Higher Education and Research, Kolar. And recently I visited Kolar as an examiner, and I came to know that none of them read my book. It doesn't matter much, but I wanted to know that there is a book like Exam Preparatory Manual written by me. If there are any questions.
Sir, thank you very much, sir, for inspiring many of the pathologists to start writing the book, because you have presented it in a very crisp manner. So whenever we talk to the students, they always say that pathology is very complex. And whenever they get a books from experienced pathologists who are taught the student for a long time, they will understand what are the difficulties of students. And your book is actually doing fantastic well. So there are feedbacks also. So I thank you, sir, for sharing your experience on this art of, the title is also very correct, art of writing a book. So I'll just check if there is any questions or this thing. So there is one appreciation, sir, from Srijan Srivastav, who said that thank you so much, sir. I am one of those who started writing but never finished it. Now I am very much motivated. So there are people who get motivated by your talk, sir. So any questions or any inputs from the audience, from the participants? I think definitely they will write to you personally, I think. So those who wanted to take tips from you, sir. thank you very much from our side, sir, for in a short notice for accepting the invitation and giving a very useful talk on writing a paper. So now I'll hand over to the organizers for a further proceeding.
Thank you, Dr. Suresh.
Thank you, sir. Thank you so much.
Thank you, sir, for enlightening us on the art of writing. Now we shall have our lunch break till 2 p.m.
Whether online lunch is provided?
No, sir.
No, you can provide. We will have lunch here. Thank you very much. Thank you.
Thank you, sir. Till 2 p.m. We shall resume at 2 p.m.
Yeah, can you hear me now? I think this is Kokilabin email ID. I can't hear you.
Ma'am, yes, ma'am. Good afternoon, ma'am.
Yeah, okay.
It's showing as a number, ma'am, 51008987.
Okay, okay. So possibly we Kokilabin का वो मुझे add करना पड़ेगा probably.
You can go to participants and you can choose your name and go to more settings and you can rename yourself, huh? If you want to rename it as your name.
Sure, why not? Why not? So I'll go to the participants.
I feel they'll join on as the session progresses, ma'am.
Okay, so participants have gone. Yes, yes. Now, what should I do? I should rename myself.
Yes, ma'am.
So shall I share my
Ma'am, initially they will introduce you, ma'am. After that, you can start sharing your PPT.
Okay. So you hear me better with my earphones or without earphones? I'm not comfortable with the earphones right now.
It's clear as of now.
Did you say anything?
Ma'am, it's clear, ma'am.
It's clear. Let me disconnect and see if.
Now we are not audible, ma'am. Next to that mute button, there is one up arrow, ma'am. If you click that, it will allow you to change the mic. So in case it was set to the headphone mic, you can change it to your system mic. Next to that mute button at the bottom, there's one small arrow. We can't hear anything, ma'am. Next to the mute button, there's an arrow. In that, you have to select the first option, select a microphone. You have to choose same as system.
Yeah, it's done.
Yeah, now it's audible.
Yes, sorry, it was by mistake. I'm in a meeting, yeah.
ಹಲೋ ವೆಂಕಟೇಶ್ ರೆಡಿ ಇದ್ದೀನಿ ಬಂದ ಕಾರು
Welcome back, everyone. Now we have a very fascinating session on circulating DNA in precision oncology from bench to clinic, and it will be presented by Dr. Amrit Kaur Kaler. And chairing this session, we have Dr. Subhashish Das, Professor of Pathology and Lab Director, and Dr. Sharad, Associate Professor in charge HOD, Department of Cell Biology and Molecular Genetics, who I would like to invite to introduce our speaker and commence the session.
Good afternoon, everyone. It is a matter of great pleasure and honor on my part to introduce Dr. Amrit. Dr. Amrit is a consultant molecular pathologist working at Kokilaben Dhirubhai Ambani Hospital, Mumbai, Maharashtra. She has very high-profile credentials, which includes fellowship and in molecular pathologies, as well as in hematological malignancies and hereditary cancers. She has done fellowships and awards, several awards in Rising Star category by the Times of India, Excellence in Research by Indus Foundation 2016, Indian Women's Achievers Award by Nair in 2016, Gaurav Acharya Award in 2017, again by Nair, and the Best Scientific Award by KCIFM. It's a great pleasure to invite her, and over to Dr. Amrit for the lecture.
Thank you so much for the kind introduction. This is Dr. Amrit Kaler, and it's a great pleasure to be online, to be talking to you on one of my favorite topics of ctDNA. Yeah, before I can start, I think I will just like to share that, I was reporting histopathology for all these 10 years. And after 10 years, I realized that, the whole of the pathology and the pathogenesis is lying inside the DNA, or it is lying inside, the nucleus of the cell. So let's get into it and let's see what goes wrong, what happens wrong. And that is one thing which motivated me after 10 years, that I want to get into genomics and see the actual pathogenesis, the actual mechanisms which happens below in that slide, in that histopathology slide, inside the nucleus and inside the cytoplasm. So it was that interest which motivated me to undergo a fellowship in molecular biology and clinical genomics. And today, with a great pleasure, I would like to bring in a lot of insights into what actually happens and what are the different techniques and how genomics is transforming the whole treatment and the management of the cancer patients. So I have a profile of 3 patients which I have prepared, through which I will make you understand how genomics is so important right now in every cancer patient to understand the diagnosis, the prognosis, the relapse, and even the treatment. So with that introduction, I think I will start with the basic definition of what is ctDNA, what is cfDNA. So we all know that in the normal circulation, we have healthy cells in a normal individual. These healthy cells break down by apoptosis. We all know in the book of Robbins, there are 2 types of breakage of cells. One is apoptosis and one is necrosis. So in the apoptosis, we see all healthy cells, and the cfDNA, which is released from the nucleus, which is basically a DNA enclosed with the histones. So these histones and the DNA is enclosed to form a nucleosome. So this nucleosome, when the cell apoptizes, and this is released into the circulation. So this is normally seen in all the healthy individuals, but in patients of cancer cells, the cells undergo apoptosis and they also undergo necrosis. The resulting DNA, which is released from the necrosis, is much heavier and bigger, composed of 150 to 200 base pairs, as compared to the smaller base pairs which are released by the apoptotic cells. So this advantage helps us to understand that the DNA, the tumor DNA, the ctDNA. So the cfDNA is the free DNA which is present from the healthy tissue and also from the cancer tissue. And ctDNA is the one which is released from the cancer tissues. So it helps us to understand about this, the monitoring of the disease, the relapse of the cancer patients, and also how the different mutations which are present on the ctDNA, it helps us to understand that aspect. So there are different types of the liquid biopsies. CTC are the circulating tumor cells, which are stained by immunocytochemistry. And this is one of the recent, remarkable discovery which has been done by Datar Medical Sciences recently has been released, that you can measure the CTCs based on immunocytochemistry, and you can identify it is from the prostate, or it is from the pancreas, or it is from the breast cancer. So it helps in the early detection of the cancer cells. So ctDNA is basically the DNA, RNA, mRNA, and all those RNAs, plus the nucleosomes, and then we have some exosomes. So we will be focusing mostly on the ctDNA. The most important part is the sample collection. The sample is usually collected in the Streck tubes because there are different methods of identification. I'll just introduce a little bit here. The first breakthrough came back in the late 90s when imatinib was discovered for the treatment of CML. And that was a time we were able to measure the BCR-ABL transcripts, and we were able to measure the response of imatinib in the form of the transcripts that were measured at 3 months, 6 months, 9 months, and 12 months. And this is the one which motivated the clinicians that why not do it in solid tumors? Why not? These are applicable in the solid tumors. And then afterwards, imatinib was also being used for this GIST, and this also helped us to pinpoint that the targeted therapy can be used for the measurements. So now there are different alterations which are present. Number one is the point mutations, rearrangements, copy number variations, and methylation patterns, which can be detected by NGS. Now we know that there are different types of techniques which are available for the measuring: ddPCR and beaming. Beaming is nothing but a different technique of purification of the DNA. And then we have an NGS. Now we have to customize each and every technique based on our profile, based on the requirement of the patient which we need. But based on the techniques, we know that ddPCR and RT-PCR are cheaper techniques. They have high specificity, they have 97.7% accuracy, and they are cheap. But the NGS technologies, they are basically higher, and they can measure the all the different rearrangements, point mutations, which cannot be seen in the ddPCRs. So the different techniques have different advantages, and we have to use it according to. So these are the different applications which we can see. The one is the prognosis determination. Absence of ctDNA after surgery is associated with a much better prognosis and smaller chances of relapse. Then we have the monitoring of the disease. Then we have the selection of the treatment if we have to undergo in a patient. Then understand the tumor mutational burden and detection of the asymptomatic patients. It also helps in measuring in sometimes a diagnosis in some of the cases, not in all of the cases. So let's see practical implications which are being used in a daily life. The number one is the metastatic melanoma for the BRAF and NRAS. Then we have castration-resistant prostate cancers on which AR amplification, AR mutations, we have a case on that. Then we have a non-small cell lung cancers in which EGFR, ROS, ALK are being measured. Then we have a hormone-positive breast cancers in which ESR1 and PIK3 are being measured for different treatment and the resistant mechanisms and as a prognostic point. And then we have a colorectal in which KRAS is being measured to know the resistance to the treatment of EGFR. So we will get into the details of the 3 cases. So this was one beautiful, a profiler for patient in which the DNA concentration was measured at the time of resection, and then it dropped immediately after the the treatment, after the surgery, and it came down at 0 level at the 10 months, and then gradually it increased, with the reappearance and with the reoccurrence of the tumor. So this is how the graph, the ctDNA actually helps us to measure the amount of the ctDNA which is present in the circulation. There was another study which compared the hormones CEA and also the ctDNA, and which showed that ctDNA was much better than the hormonal treatment in measuring the onset of the tumors 3 months before it presents clinically. So this is one graph. And before I get into the cases, this ACMG guidelines are significant to understand the reporting of the NGS. Tier 1, Tier 2, Tier 3, Tier 4 are the different reporting methodologies. Tier 1 is therapeutic, in which the gene which is seen in that particular tumor is diagnostic, and it is also prognostic, plus there is a therapeutic medicine available for the treatment of those patients. Now, Tier 2 is the one which is diagnostic and prognostic, but there is no therapeutic evidence, or there is no therapeutic treatment available for that particular tumor in that particular patient. So that's what is the precision oncology comes into, that we provide a right diagnosis at the right time to the right patient. So this is what precision oncology is. So Tier 3 is, there's a variant of unknown significance which has not been proven pathogenic in any of the cases. And Tier 4 is the benign or the likely benign variant. So apart from the introduction, let's start with the cases. We have 3 interesting cases. Case number 1, a 59-year-old male, he was diagnosed with the prostatic adenocarcinoma, and the PET-CT showed a nodal disease, but after the surgery in the prostatectomy specimen, we didn't get a lymph node. It was a high grade with the Gleason grade of recent grade group 5, and the PSA was on the higher range. So the patient was started on androgen deprivation therapy to the Abitron, and PSA was gradually reduced to 2.12. For 2 years, he didn't have any symptoms. But after 2 years, again, a patient showed a progressive disease, and he presented with a multiple bone metastasis. And then again, the patient was started with enzalutamide and denosumab. So the patient responded very well on these treatments. In 2020, again, the new bone metastases were there, and the patient showed symptomatic progression. So in this case now, a liquid biopsy by next generation sequences was advised in this case, not ddPCR. We should know ddPCR just measures 4 mutations, maximum 4 mutations at a time. But in NGS, you can measure based on your sample size, based on your mutation size. Maybe it can go up to 500. So in the ctDNA, we found that the TMPs were 13. The tumor percentage on the slide was quite good, 50%. And the tumor mutational burden showed 13 mutations. MSI was stable. And among the genomic findings, we had androgen deletions, and there was an AR7 splice variant, which showed a frequency of 18.3%, which is a Tier 1. Then we had a CDK12, which is 6.2%. AR amplification was seen very significantly. And then we had this temporous ERG translocation, 5.7%. I think we all have heard about this translocation. PTEN loss, TP53 was also there, and EGFR was 5.3%. So based on such a huge genomic data which was generated to us, we wanted to get into the hereditary germline panel as well. And we saw that the patient has a HOXB13 gene mutation. Now, let's see, what are the treatment options right now? Do we continue the patient on Abitron, or we want to give him enzalutamide, or we want to give him a Taxol therapy, or an EGFR therapy, or we want to give him immunotherapy in the form of pembrolizumab? So based on this scenario and the mutations which were present, we knew that we had these mutations. Now let's see how to decide on a patient in this particular situation. So let's see, what is castration-resistant prostate cancer? It is a lethal clinical state which continues to grow after bilateral orchiectomy or on treatment with LH-RH agonist, or even after continuing with the non-steroidal anti-androgen therapy. So basically, after we have prostate cancer, we have an active androgen receptor, we give him an androgen deprivation therapy, and still the patient is not responding. So this is the situation which we are facing here, castration-resistant prostate cancer. So we see that the receptor, it behaves in multiple forms. You can see mutations, you can see overexpression or increase in copy number variations, or you can also see some splice variants in the mutation. So now if we see on the left side, we have AR overexpression. There's an increase in copy number. The number of genes has increased. So with the result, there's an increase in the number of pathways, and there's increased stimulation of the receptor, and there's an increase in PSA, and hence the increased tumor formation. And then we have the AR mutations which are present, and these will also lead to the similar pathway. And then we have some resistance mutations in which the androgen independent activation will happen of the receptor. So that is also another one pathway. So let's see how the androgen receptor behaves. So in this particular patient, this is the X chromosome, androgen receptor is present on androgen gene is present on the X chromosome. We have exon, and then we have, this is the gene number of domains which are present. We see the transcript here, but if we see the ARV7, the deletion that we saw in this particular patient, there is nothing after this. The LBD, the ligand binding domain of the patient's gene is almost missing. So what happens is, even though the treatment is available, it is not able to bind to the LBD, and it is not able to perform its function. It is not able to inhibit the androgen receptor. All right. So this is what is happening in our patient. So let's, before we get into the treatment part, let's get back to the basic picture in the Robbins that we used to see, that from the adrenals, DHEA is produced, which is converted into testosterone, which is converted into DHTs, and then the androgen receptor. So what happens is, we have this ebitron, which inhibits this enzyme here, and inhibits the formation of testosterone, and then it fails to bind with the androgen as a ligand, and it fails to stimulate the nucleus in androgen receptor in the nucleus, because androgen is a nuclear receptor. Now the next one is enzalutamide. What it happens is, it inhibits the androgen from binding to the receptor here. So with the result, it doesn't bind, and then there is no stimulation. So there are certain side effects of these, which we will have to deal with on a daily basis. So we understand the receptor, the gene, and also we understand the drugs which act on it. So now this is the recent advances in which there are definitely some genes which are involved in the progression of the cancer from the normal prostatic epithelium to high-grade PEN to prostatic adenocarcinomas. So we can see that as a MYC overexpression, there's a loss of PTEN, TMPRSS, ERG fusion, which we saw in this patient, and then we have an RB gene, then FOXA1, and all these genes which can be involved in the metastatic prostatic adenocarcinoma when it gets to the distant sites. So this is important to us as a pathologist, but when we look at the genomic pathways, we have almost seen a lot of mutation on the right side in TP53. There can be a mutation in the cell cycle, there can be a mutation in the PIK3 pathway, in WNT pathway, DNA repair pathway, in the AR associated, and also in the chromatin remodeling. So in practical uses, we have seen that the mutations were more in TP53. So this is how we look at a genome of a person. And just a new line on the patient, that when the patient has a high TMB, this patient showed a high TMB of 13. So with the high TMB, we have a high new antigen load. With the result, when the new antigens or the new receptors are stimulated or they are exposed to the circulation, the lymphocytes will go and act against them, and they will try to destroy the cancer cells. So that is why high TMB is a very good marker for immunotherapy. So it enhances the anti-tumor immune response. So let's look at the tumor treatment options. That tumor vaccines are also available according to the NCCN guidelines. These are available for the treatment. So we harvest the patient's cells, incubate them with the antibodies which go and act against the PAP secreting cells and will destroy the tumor cells. And also we have immune inhibitors which are being used for the CRPCs. So let's see, what was the recommendation from the genomics department? We saw the AR amplification, androgen amplification. We had an ARV7 splice variant, and which were associated with the poor prognosis. And then we had a TMPRSS ERG fusion, which were associated with the poor prognosis because we haven't got a predictive treatment for this particular fusion. And then we had a Hogspeed germline mutation, which is very, very commonly associated with the prostatic cancer. So now, since because of the amplification of splice variants, there will be a resistance to both the hormone therapies. Now we understand why, because the treatment, the drugs which were supposed to bind on that LBD, that part is missing. So the treatment is not working. The patient is progressing and he's coming back with the multiple metastasis. So, and the one very good important point is that ARB7 may respond very well to the taxane therapies. So, and also it has been seen that the HOXP protein mediates the AR7 activity in the prostatic cancers. And the thirdly, high TMB and CDK12 paves the way for the immunotherapy. So the recommendations from the genomic departments was to stop the steroid treatment, start with the taxane therapies, and put the patient on immunotherapy, and the patient will improve. So now we can see that how a castration-resistant prostatic cancer need to be genomically understood. Each gene need to be understood, and why. You need to understand your pathways and how the treatment will work. Sometimes there's a cross-talking between the pathways. If there are RAS and PIK3 pathways, you inhibit one, the other one gets activated. So you might, sometimes you have to put them onto one or two targeted therapies so that both the pathways are inhibited. So it's very important to understand that part. And so when the genomics department gives a report of an additional, treatment that we can give it to them as immunotherapy, the medical oncologist is really happy that now he has something to work on. So I'm sure I was clear in my talk. And let's go to the case number 2. In the case number 2, we have a 60-year-old woman, never smokers, and she presented with a shortness of breath, and she was diagnosed with a lung adenocarcinoma. PET-CT showed a metastatic disease with the involvement of the lymph nodes, and the tumor tissue, which was sent for initial diagnosis for the EGFR, was insufficient. So we had to collect a circulating tumor blood sample with the Streck tubes, and then sent it for the ddPCR analysis for EGFR. And NCCN guidelines have actually recommended that we should use the ddPCR for the detection of EGFR mutations. So the results came, and the result was positive for exon 19 deletions. And the patient was started on the first line therapy with the EGFR tyrosine kinase inhibitors. So let's see how to approach this. If we have a case of non-small cell lung cancer, there is a reflex testing, which NCCN guidelines have recommended that whichever non-small cell carcinoma is presented, a reflex testing for EGFR has to be done on each and every case. So after we do that, if you get the mutation, you start the patient on TKI, tyrosine kinase inhibitors, and if the sample is insufficient, you put the patient, or you take the blood sample and you detect the mutation and start the treatment. Now part B, after 1 year of TKI therapy, the patient again showed a progression of the disease, and there were multiple liver and root metastasis. Again, COBAS B2 was used for the resistance mutation, which is mostly T790 mutation, which is being seen in these patients. So we did get the mutation, and then the patient was started on osimertinib. So let's see, how do you approach this case? So now if you get a T790 mutation, you start them on 3rd generation tyrosine kinase inhibitors. And the same happens if you don't have enough tissue. We take the blood sample and help the patient. So this was the graph which we obtained, for both the exon 19 mutation and T790 deletions and new mutations. And after starting the 3rd generation TKI, both the mutations went down, and the patient was disease-free after some time. So this is what happens. What is the proposed use of liquid biopsy? We have a diagnosis, we do the molecular testing, we start the TKIs based on the mutation, and then we look for the acquired resistance. If there is a resistance, you put them on 3rd generation TKIs. If the patient is not responding, or if the patient does not have T790 mutation, you put the patient on chemotherapy. So in this way, you are able to detect the disease, the relapse, assess the resistance and the tumor heterogeneity, and you are serially monitoring the response of the treatment. So let's talk a little bit about the EGFR mutation. EGFR mutation is found in 14 to 38% of the patients of non-small cell lung cancers based on the geographical location and ethnicity. It is about 85% of all the lung cancers and is a cornerstone for the management of the advanced stage diseases. And these are surprisingly very common in women, and they are non-smokers and in the Asian population. So EGFR targeted therapies are definitely superior to chemotherapy in terms of overall response rate, in the progression-free survival, and in the quality of life for patients, and that has already been proved. So let's know our gene. It's whenever we get a genomics report, we are very excited. Okay, which gene has come positive, and we get into the depth of it, which exon, which codon, and we get into the pathogenicity, how good or how bad it is, what's the effect of the gene on the immune response, what is the effect of the disease on the response to the treatment, and how the gene will respond over time. So this is something which is daily to look forward to every day when we come back in the lab and we want to understand our gene, how is it? So let's see how the EGFR gene is. It is one of the most studied gene, and this has been typically the 4 domains. And out of all these, we have 4 exons, which are very, very significant and has found to be pathogenic: 18, 19, 20, and 21. Exon 19 is the most commonly seen in the Asian population, constituting about 45% of all the mutations, and then followed by 21, and then followed by 18 and 20. And the mutations which are in dark color, they are supposed to be associated with the drug resistance, and of which the T790M, which we discussed in the case, is the most common one, followed by L858R mutations, and then we have the other mutations. So now recently, exon 20 insertions also have become very, very a matter of topic of interest, since these patients behave very badly and they don't respond to tyrosine kinase inhibitors. So let's look at our gene. We have the membrane receptor EGFR, which has a binding ligand, and then we have a domain where all the mutations are seen here. So now we see the first generation TKIs. We have gefitinib and erlotinib. They bind reversibly with the mutation and they inhibit the exon 19 mutation, but they have no effect on T790. Second generations were discovered after that, and they bound irreversibly to the exon 19 deletions, and they had a better efficacy, but still they were inactive against T790 mutations. The third generation here, osimertinib, it irreversibly binds to the EGFR, and it is typically specific to the T790 mutations. And now you can see if there's a one gene mutated, there's an activation of 3 different pathways: PIK3, RAS, and JAK. And all these are involved with the gene transcription. They are involved with the proliferation, survival, and the migration, epithelial mesenchymal transition, and all those things. So let's go back to our algorithm once again. If we have a first generation, we use for first generation TKIs against 18, 19, and 21, and then you look for T790, then third generation. If it is negative, we get back to the chemotherapy, look for the clinical and radiological response. And if still the patient is progressing, we do a PD-L1 testing, and then that is based on CPS or the TPS scoring. And then we have the immunotherapy drugs, nivolumab, or all these trials are going on, but it has already been established that immunotherapy works very well in non-small cell lung cancers. So if there is a resistance to the third generation TKIs, osimertinib, so what are the different other pathways which can be formed? There is recently one new mutation, C797S mutation, which has been reported even into the third generation TKIs. Or there may be some other pathways, not only the EGFR, but there are other mutations. There are 7 to 8 different mutations which has been found: ALK, ROS, MET, TRED. So all these mutations might have been activated along with the EGFR diagnostic 4, or maybe some other pathways. Or there is a transformation to the small cell lung carcinoma that is also very, very significant, because these treatments doesn't work in there. So as a pathologist, if you are able to see adenocarcinoma and also a small cell lung carcinoma on the slide, please don't go ahead with the EGFR because the patient will not respond to the treatment. Or there is some other cell cycles which are involved. In 2021, this was the, I love this chart. This was released by COO, Clinical Care Options, that they carry a very good webinars for all the treatment of molecular markers. And they explained very nicely the treatment for each and every mutation which has been found in lung cancer. ALK, we have elicitinib, ROS, we have crizotinib, BRAF, dabrafenib, NTRK, entrectinib, RET, and MET. All these are, we have a targetable mutation therapy available for all these mutations, and which really fascinates me to understand how you can help the patients. I sit in the OPD every day and I deal with 3 to 4 patients who are at an advanced stage, or they have gone to the metastatic stage. And when I tell them, we will do this bigger panels and we will find out the mutation which is causing you this progression, and I see the smile on their face when I tell them yes, they have a treatment. I mean, that is amazing, and that makes my day when I go back home. So I think for the lung cancers, there's a lot of treatment options which are available, and they're much better than the chemotherapy. So before I end this case, I wanted to tell you talk about what is tumor heterogeneity. So tumor heterogeneity is basically, presence of multiple mutations in the same tumor, or the presence of the different mutations in the same type of tumor, but in the different patients. So now you can see, and there are 2 different types, the spatial and the temporal. The spatial is the one which have different clones. And in one tumor, suppose this is non-small cell lung cancer, we have 3 different clones and 3 different mutations. Possibly we have an EGFR, ROS, and ALK, all 3 of them. It doesn't exist together. This is just an example. So you might take a biopsy from the subclone 3, but you might have missed on subclone 1 and 2. So that is why it is very crucial when you select the slide for your reporting, that if you have got a small biopsy, or if you have a pattern, if you have a slide with one pattern, or if you slide with the multiple patterns in the slide, it's better to pick up a slide with the multiple patterns, because again, the transition would have happened, the mutation would have been much more, which can be picked up on the slide. So that's why the percentage, the cutoff percentage while selecting the slide is more than 30 to 40%, and just not to miss on any of the mutations. So the second one is a temporal. Temporal is the way which we look into EGFR. Initially it was exon 19 mutation. Then the 21 showed a T790M mutation. So with the response, with the resistance to the treatment, the progression happens. So this is temporal heterogeneity, which we saw in this particular tumor. So both these phenomena we see very regularly in our reporting, video reporting. So this was just a brief view that the patient responded to gefitinib, and then the other clone reappeared, T790M, and then we treated the patient on osimertinib. So this is another one of my favorite slide, in which we are trying, elephant is the tumor, and we are trying to see its genomics and microbiomes and immunogenomics and metabolites. We just want to get into it. What went wrong? What is the pathway? What is the product which is going wrong in the patient, so that we can help the patient get back to his normal life. And I have seen it with my own eyes. Immunotherapy really helps, and it has transformed the way the things are happening, and people are very happy with the targeted therapy. The reason is, it's an oral chemotherapy. You don't have to take it IV, and the targeted acts only on the tumor cells. It does not act on the normal cells. So it just helps the patient, like a morning B complex dose. So you take the targeted therapy. So this is us. We are the 6 blind scientists looking for all the answers, and so I end up with the second case. Now I have a case number 3. A 43-year-old female with a mass on the right breast and the bone metastasis. The histopathological diagnosis was infiltrating ductal carcinoma, no special type. ER was strongly positive, PR weakly positive, HER2 was negative. So PET-CT showed a progressive disease. And since it was already a metastatic and ER positive, so the clinician went ahead with the PIK3 testing. So it was positive for E544K. So with this thing in mind, I think the patient was started with aromatase inhibitors, alpelisib, which is very, very particular for PIK3 and something for the bones. So 2 years later, she had a reoccurrence and there were no new lesions in the liver. So again, the liquid biopsy was taken for genomics by NGS for a bigger panel. So these were the findings. Again, the tumor percentage was quite good on the slide. We had a TMB. This is a liquid biopsy, so not on the slide. So the tumor TMB is 22 mutations. So MSI is stable, and the BRCA2 gene was tier 1. It was 48.3. So this was a clearly this is giving an indication of hereditary breast cancer. RAD51 and PALB2, again, these are a part of the homologous recombinant pathway. These are in the DNA repair pathway. We will talk about it. Then PIK3A and P10, they were lost together. Again, this was one of the reasons, but not a major reason for pathogenesis, as we can see based on the percentages of MAF. So PIK3 and P10 are all interchangeable. We all know that P10 inhibits the PIK3 pathway. It is a tumor suppressor gene. So even if the PIK3 is normal, P10 is lost, the inhibition on the PIK3 pathway is lost. So again, there will be a tumor progression. So P10 loss is also very significant when we get it on the genomics report. And also P53 hotspot mutation, P45 was 5.2%. So based on that, we did a genomic germline screening. And we found that the patient was positive for BRCA2, which is likely pathogenic. It was heterogeneous, but it was a part of hereditary breast and ovarian cancer, which was in the autosomal dominant inheritance. So before we get into the BRCA gene, I just wanted to specify on the penetrance, because when we are dealing with the germline major gene, the penetrance of the gene is very, very significant, because especially in BRCA1 and BRCA2, even if it is 50%, the chance of getting the cancer, the whole lifetime risk of cancer is 60 to 80%. Breast, and around 40 to 60% in the ovary, and 20 to 40% the pancreatic. The penetrance of the gene is quite high. But there are some genes which are germline, like ATM, CHEK2, PALB2. Even if they are present, the chances of getting the malignancies is moderate. You might have a percentage which is a moderate percentage. So now, as we have reported the mutations as tier 1, tier 2, or tier 3, we report the germline mutations as pathogenic, likely pathogenic, or uncertain significance. So the pattern of reporting between a somatic and a germline is slightly different. So the penetrance of the gene is something to be looked into. So let's go into our BRCA1 and BRCA2 gene, which is something which everybody is quite aware of, that because this has been there in the talk since quite a long time. So it's a tumor suppressor gene. It has a capacity to repair damaged DNAs. So through a process known as double DNA strand break repairs pathway. So if the patient has inherited one of the mutations and there's a loss of heterozygosity, LOH, it predisposes the cells to chromosomal instability, and which leads to the malignant transformation and cancer development. So these genes, BRCA1 and BRCA2, forms about 80 to 90% of the cancer-positive genes in the hereditary breast and ovarian cancers. So let's look at our pathway. So what happens is, this is the homologous repair pathway. Whenever there is a radiation or a mutation, these are the genes which get activated. With the result, ATM gene, which is in the pathway, will get activated, and it will activate the CHEK, it will activate the BRCA1 gene, and it will activate the P53 gene. So CHEK2 will arrest the cell cycle. BRCA1 and BRCA2 will go back to the mutation, and it will try to repair the mutation, or a change in the nucleotide which happens, or there is something else which is formed, which I will show it in the later slide. So it will try to repair the mutation which has happened, and if BRCA is not able to repair, then P53 will give the signal that apoptosis should happen, and this cell cycle will not go ahead. So this is how our body works wonderfully, by keeping a checkpoint on every mutation or every change in the nucleotide in any form. So this is our homologous recombinant repair pathway. Now you can see there is a BRIP1, which is also very common, PALB2, RAD51, BARD1. These are all the genes in the pathway which are significant, and mutation in any one of the genes will lead to a genomic instability. So let's see what happens in a healthy cell. If there is a damage, there is a single strand break, one nucleotide change, you may find a ducts or the fusion of the two different nucleotides, or you may find a base mismatch or incisions or deletions, or you might find double strand breaks. So when these happens, there is a repair involved with it. So base excision repair and nucleotide excision repair of the adducts is done by PARP. It is again an enzyme which helps in the repair. Then mismatch, insertion and deletions is repaired by the MMR genes. And then this homologous and non-homologous is done by BRCA1 and BRCA2. So this is the normal repair which the body does in in the normal process. So what happens if there is a mutation in any of these? The BRCA1 and BRCA2 is impaired, with the result there is a no repair here, and there is a genomic instability and the carcinogenesis. Now you understand how the genomic instability happens with the mutation in any of these genes. I really like that this defined a BRCA1, BRCA2 gene very aptly. The DNA checks itself before it wrecks, before it destroys by p53. It checks itself, it tries to ligase it, it tries to heal it, and if it doesn't happen, it destroys the cell. So this is a very good message here. So now what happens is this homologous repair pathway, it is done by BRCA1 gene mutations or even the promoter methylation. All this leads to the inability to repair DNA and genomic instability. So there are multiple pathways. There is a germline, there is a somatic, and then there is a hypermethylation. That is what we're trying to say here. So with the result, there's a deficiency in the repair. So when there's a deficiency in the repair, this deficiency is known as genomic scars. And now there's a new technique, HRD, which measures these genomic scars on the basis of LOH, LST, and TAI, loss of heterozygosity, large-scale state transitions, and telomeric allelic imbalances. So this is a new technique which has been validated, and how much it is helped clinically for the patients, that part is still under validation. But this is the measure, HRD, homologous recombinant deficiency, is being measured in the form of this genomic scars. So these PARP inhibitors, basically, the usage of PARP inhibitors in the patients which are BRCA1 and BRCA2 positive is very, very fascinating. What happens is, if it's a normal cell, PARP is the enzyme which does the repair. And if we give the patient chemotherapy, the PARP will go and repair that damage and the cell will survive. So there is a resistance to the chemotherapeutic agents. But if the cell is BRCA deficient, so the repair is not happening properly. So if we do the inhibition, immediately the cell death will happen and the patient will respond. So this is known as finding the Achilles heel in the BRCA-related cancer. So in fact, BRCA gene positivity is a good news for the patient. It carries a good prognosis. So now you can see this BRCA gene is being seen in the endometrial, in all sorts of cancers nowadays. And we run a HPOC panel, we run a bigger panel, and we see that it is being almost seen in many of the cancers. So this is one slide before I talk about the treatment of this particular case. We have PD-L1 and inhibitors which are being used. We know that the tumor cells express the PD-L1 receptor, which binds with the PD-1, which is present in the T cells, and it inhibits the T cells from acting against the cancer cells. So now the treatment is available, which I've discussed before, and ipilimumab is acting on CTLA4, which is also shown very good results in solid tumors. So let's see, we saw a BRCA2 gene was positive as a part of hereditary breast and ovarian cancer. So what is recommended in this particular case? Platinum therapy is very much recommended because BRCA1 and BRCA2 genes are very, very sensitive to platinum therapy. Plus, we can put the patient on PARP inhibitors because, again, the response will be very good. And if letrozole can be given because of the AI, but depending upon the age, she's a younger patient, not a postmenopausal, so letrozole again can be kept on hold, but we can put the patient on immunotherapy. But the initial ampicillin, which we had given for PIK3 inhibitors, can be ruled out. So now we can see how drastically genomics is changing the treatment of the patients. So this is also something the lady is asking, and this is from the Spider-Man. Tell me the truth, I'm ready to hear it. So Spider-Man is giving in the news, your NGS shows a driver mutation. There is a drug that can save your life, but he says you can't afford the drug, and there is neither a clinical trial or a compassionate access program. So I think we entertain ourselves by doing all this. So we have a colorectal malignancy in which the KRAS mutation was measured, and it helps us to understand whether the anti-EGFR therapy can be given to the patient or not. So these are some of the genes which are being commonly used for the treatment, and these can be measured and by ddPCR or RT-PCR, depends upon your lab how you want to do it. And then this is a very good statement by Dr. Laura. Identifying specific mutations in a tumor can reveal potential treatment opportunities, either with the approved medications or as a part of the clinical trials that are tailored to that cancer and that might not otherwise be considered. So all patients with metastatic breast cancer should talk with their oncologist about whether their cancers should be genomically profiled. So this is my hospital here in Kokilaben Dhiruvayamani Hospital, and I would really like to thank the organizers for giving me this opportunity and for letting me share my cases here. And I would especially like to thank Dr. Kalyani, who's my teacher, who's my mentor, and my very good friend for bringing me here to the forum. Thank you.
Thank you, ma'am.
Yeah. I'm ready to take any questions if they are there.
No questions, ma'am.
Oh, was it so boring or it just went over the head? But I'm telling you, we pathologists have an ample opportunity right now to get into the genomics and the pathways which were very difficult. I used to find very difficult all these pathways in the first 10 chapters of the Robbins. And I remember I had a tough time learning them and writing part 1 of path paper, but now they have become my day and night, my passion, why the genes are responding to which particular treatment, what should I give that the other pathway does not get activated. So there's a lot of science involved, and it's fascinating when you see patients improving, and that's something which carries you all along. So I think we should, molecular pathology is something which is, I think, coming up very fast, and I think we should dive into it. All right, thank you so much. All right, then, that's it.
Sharat sir?
It was a wonderful presentation because it was very exhaustive, from fundamentals of mutations in cancer to their heterogeneity, diversity in the genes involved, molecular pathways both in the tumor and their residues, post-apoptotic residues in the circulation. So initially I thought it was only the circulating DNA that will be touched upon, but even the source and their causes why they carry those mutations and why they do land up in the blood and other liquid samples were discussed. And I think that has given in a very nutshell what would have otherwise been missed in a tissue specimen. We can see this is the limitation, I think, that the current science is trying to help us to bridge, that we can see what is otherwise not possible to see in the whole tissue. Here we are trying to look for individual molecules and individual damages. But again, Madam has also been able to show that this is a very daunting task because it is highly complex. So that also opens up a lot of opportunities for research and more investigation to see to map what exactly matches with what kind of a response. So I would like to thank the organizers to bringing together such a eminent, experienced people to this gathering. I thank the organizers, and I would also like to appreciate and congratulate the speaker for the wonderful information given.
Thank you. Thank you.
Thank you, ma'am.
Thank you, Shilpa.
So this is where we end our scientific sessions, but worry not, as now we have our exciting segment of the quiz. And as the quiz master, I'm calling upon Dr. Shilpa to tell us about the rules and regulations. Over to you, ma'am.
In the brochure, we have given it as 3 o'clock. So sharp 3 o'clock, we'll start the quiz. Okay. Good afternoon. So rules have already been sent through your emails, but I'll be repeating once again. Quiz will be conducted on Kahoot. Each participant will need 2 devices to participate in quiz. The one in which you will be viewing the questions, that is on the Zoom, which should preferably be a laptop for better visualization of the images. And you should have a second device that will be a mobile phone on which you will be answering the quiz. And to participate, you can use browser and enter the URL, that is www.kahoot.it, or join through the app which you have downloaded already. And game pin will be provided, and after entering it, you have to enter through your nickname as CME registration number followed by name and college. For example, if your registration number is 105 and your name is whatever it is, and you are from SDMC or some other college, you have to enter it as 105 and Swaroop at SDMC. Okay, so in this way you have to enter. Then every participant should participate using only one device. On Kahoot, the score is based on getting the right answer and time taken to the answering the question. Hence, both speed and accuracy matters to the final score. And the answers mentioned are final, and no challenging of the scores or answers are allowed. Then coming to the prizes, 3 prizes will be given for the postgraduate category and 1 prize to the consultant or faculty category. And only 1 PG from an institute is eligible for the prize due to possibility of the discussion in online quiz. So all of you can go to this URL www.kahoot.it. Okay. We'll provide the game pin. So this is the game pin 1765268. Okay. Participants kindly join first. Join through www.kahoot.it and enter this game pin, okay, by using your register number, name, and your college name. Participants join using www.kahoot.it and enter the game pin. Okay, we'll be starting the quiz. So there are 80 questions. Okay, here it goes. Skip, sir. Second question. Third one. Last question of the quiz. Thank you, participants, for participating in the quiz. I hope you people enjoyed the quiz through this Kahoot. We will be announcing the winners within 10 to 15 minutes. Hold on.
Good afternoon, everyone. As we come towards end of today's session, I think all of you must be waiting to know about the results. Now, in the PG category, the third prize goes to Dr. Aswati P. from Government Medical College, Kottayam. The second prize goes to Dr. Abhishek Singh from Commando Hospital Air Force, Bangalore. First prize goes to Dr. Aparna Devi C, Kidwai Memorial Institute of Oncology. In the consultant category, the only one prize which was announced goes to Dr. Anita Hebbar from Melaka Manipal Medical College. So congratulations to all the winners. E-certificate will be sent to your registered emails shortly. And the prize money will contact you for your bank details, and then we will send the prize money. Now I invite Dr. Swaroop Raj, Organizing Secretary of today's CME, to give the vote of thanks.
Good evening, everybody. So this brings us to the end of today's CME. It's my privilege to propose the vote of thanks. Firstly, I'd like to thank our late founder chairman, Shri R.L. Jalapaji, for providing us the infrastructure and support to help us conduct such academic quests. Further, I'd like to thank our patrons, our President SDUET, Shri G.H. Nagaraja sir, Vice President SDUET, Shri Rajendra sir, Secretary SDUET, Shri Hanumant Raju sir, Honorable Chancellor, Shri Rajesh N. Jagadale, Honorable Vice Chancellor, Dr. Pradeep Kumar Ji, and Registrar SDUHER, Dr. KNV Prasad, for the constant support in our endeavors. I'd like to thank our speakers for today's sessions, Dr. S. Rajendran sir from Shri Ramchandra Institute of Higher Education and Research, Dr. D.N. Lanjevar sir from Gujarat Adani Institute of Medical Sciences, Ramdas Naik sir from Yenepoya Medical College, and Dr. Amrit Kaur Kaler from Kokilabai Dhirubhai Ambani Hospital, without whom this event would not have been possible. I'd like to thank our HOD, Dr. Kalyani R, and my colleagues, postgraduates, and other non-teaching staff, without whom the CME would not have been possible. I also would extend my gratitude to the IT department, photography department, AV Hall for their constant support. Thank you, one and all. Feedback forms will be sent on your email IDs. So once you fill the feedback form, within 48 hours, you'll be receiving your e-certificates. If you have any queries, you can get back to us by email or you can contact me directly.